So fertilization, fusion of male and female pronucleus, formation of zygote. Now, zygote enters the uterine cavity on day 4th after fertilization. After fertilization. So implantation occurs in the form of blastocyst. So blastocyst implants deep inside the endometrium. So this is called as interstitial implantation. This is called as interstitial implantation. So what is the timing of implantation? It starts by 6th day and ends by 10th day after fertilization. So what is the most common site of implantation? So upper part of uterus, posterior wall of uterus. Upper posterior wall of the uterus is the most common site of implantation. So what is the first sign of pregnancy on ultrasound? First structure on ultrasound. So first structure is intradecidual sac sign. Intradecidual sac sign is the first structure on ultrasound in early pregnancy. So earliest finding of intrauterine pregnancy on ultrasound, double decidual sac sign. Double decidual sac sign. Sac sign is the earliest finding of intrauterine pregnancy on ultrasound. So in this image you can see blastocyst is surrounded by 2 rings. So inner one is decidua capsularis, and outer one. This one is the outer ring. So outer ring is called as decidua parietalis. Decidua parietalis. Decidua parietalis. So this is the second sign of pregnancy on ultrasound. Decidua, double decidual sac sign. So third one, most definitive sign of intrauterine pregnancy. So what is the most definitive sign of intrauterine pregnancy? Double bleb sign. So this is double bleb sign. Double bleb sign. So look at this image. Formation of gestational sac with 2 bulbs. So these are yolk sac and amniotic sac So this is called as double bleb sign. So clear? First sign on ultrasound in early pregnancies, intradecidual sac sign. Second one, double decidual sac sign, and the third one, double bleb sign. Now, so what are the critical values of beta-HCG beyond which gestational sac should be visible in 100% cases of intrauterine pregnancy? In TVS, transvaginal sonography, in transabdominal sonography. Yes, in TVS more than 2000 international unit. In TAS, transabdominal sonography, more than and equal to 6500 international unit. So this is a critical value of beta-HCG. Means we are sure if pregnancy is here, intrauterine pregnancy is present. So if the value of beta-HCG is more than 2000 without visible sac, suggestive of ectopic pregnancy. Ectopic pregnancy. So gestational age estimated by ultrasound. best parameters on ultrasound to check exact gestational age. In first trimester, round lump length, CRL in first trimester. In second trimester, biparietal diameter of fetal skull, BPD, biparietal diameter. And third trimester, femur length. First trimester, CRL, second trimester, biparietal diameter, and third trimester, femur length. Okay. Now, early signs of pregnancy. Softening of cervix is called as softening of cervix. Goodell's sign. This was a PYQ. Isthmus softening is called as Haggard's sign. Bluish discoloration of cervix and vagina, Chadwick sign or Eclampsia sign. Pulsation felt through vaginal fornix, Osiander sign. This is a Osiander sign because of high vascularity. These signs are very, very important for exam. Asymmetrical enlargement of uterus due to lateral implantation. So this is called as Piscascake sign. Yes. And the last one, regular rhythmic contraction is called as Palmer's sign. So these are the important signs in early pregnancy. Now, moving toward next topic, that is placenta. So placenta is a discoid, disc-like, hemochorial and deciduate. It sheds after delivery. So weight of the placenta at term is around 500 grams at term. Weight of placenta. Thickness of placenta is around 2.5 to 4 centimeters. If the thickness is more than 4 centimeters, this is called as placentomegaly. So this is called as placentomegaly. So there are two sides of placenta, maternal side and fetal side. So this is a PYQ. Fetal side of placenta is formed by. So this is formed by chorion frondosum. Chorion frondosum. And maternal side of placenta is formed by decidua basalis. Decidua basalis. So volume of placenta at term. So volume is around 500 ml at term. 500 ml. So placenta is a highly vascular. That's why in case of placenta previa, per vaginal examination is contraindicated. जैसे ही टच करेंगे प्लेसेंटा को ब्लीड हो जाएगा because placenta is highly vascular. So at term volume is around 500 ml. In intervillous space volume is around 150 intervillous space. In fetal side, inside the villi, volume is around 350 ml. 350 ml. So now, at term, placenta is composed of fetal blood and maternal blood. Highly vascular, but there is no mixing of blood. Only exchange of oxygen and nutrient. No mixing of blood. So what is the reason? There is no mixing of blood. Placenta is composed of fetal and maternal blood because of placental barriers. So what are the structures separating maternal blood from fetal blood? So first of all, syncytiotropoblast, then cytotropoblast, then extra-embryonic mesoderm, then fetal capillaries. So look at this image, placental barriers. So outer layer, this one, this blue colored layer, this is a syncytiotropoblast. Then this one is a cytotropoblast. Yellow part, extra-embryonic mesoderm. Then inside, fetal capillaries. These are fetal capillaries. So these structures are called as placental barrier. Now moving towards next topic, placental abnormalities. So this is a PYQ. Look at this image and tell me name of this placental abnormality. A small lobe of placenta separated from main lobe remains connected with blood vessels. This is a small lobe and this is a main lobe. So this is called as accentuate lobe. Accentuate lobe. Small lobe and big lobe, like this. So this is a small lobe and big lobe connected with blood vessels. So this is a accentuate placenta. So what are the complications associated with this abnormality? What are the complications at the time of delivery? Secondary PPH, postpartum hemorrhage. So what is the most common cause of secondary PPH? Retained placenta. So secondary PPH due to retained placenta. Other complications, infection, sub-involution of uterus, and there could be a placenta previa. So these are the complications which are associated with placenta accentuate. Now, two equal lobes of placenta are separated from each other. This is called as bilobata. Again, complications, secondary PPH, which are associated with bilobata placenta, infections, abruption. Okay. Now, cord attached to margin of placenta. Normally, cord is attached. So this is the placenta. Normal attachment of cord, the center of placenta. So in this image, cord is attached margin of the placenta. Lateral attachment of cord. So this is called as battledore placenta. Marginal or lateral insertion of cord. So what are the complications? Complications with battledore placenta, cord injury at the time of delivery. Cord injury, fetal blood loss, then fetal distress. So this is called as battledore placenta. Now, so this is a velamentous insertion of cord. Cord first attached to membranes, then to placenta. Attached to membranes, then to placenta. If the velamentous insertion of cord is present over the internal oats, this is called as vasa previa. So during delivery, after rupture of membranes, there is an increased chance of cord injury, which leads to fetal blood loss. This is called as velamentous insertion of cord. Normally fetal surface and maternal surface both are same, equal, okay, but at time fetal side is smaller than maternal side. Mean fetal side is small and maternal side is big, and fetal side is surrounded by maternal side in the form of ring. So this is called as extrachorial placenta. So there are two types of placenta. First one, circumvallate placenta. Circumvallate placenta. And the second one, circummarginate placenta. So in case of circumvallate, there is a thick wall-like membranes are present around the fetal surface. So circumvallate placenta, fetal surface has a central depressed area and surrounded by a thick membrane of folds of amnion and chorion. So in case of circummarginate, there is a thin membrane present at the chorionic plate. In this case, both surfaces are at the same level. So this is the difference between circumvallate and circummarginate placenta. This is a PYQ. Solve this question. A 𝗘𝗱𝗶𝗁𝗋 woman underwent cesarean in previous pregnancy for fetal distress. This time she had an uneventful vaginal delivery, but the placenta couldn't be removed completely. She also started to bleed more profusely now. So what is the cause? So option is C. So this is case of placenta Accreta. This is a case of placenta Accreta. So what is placenta Accreta? So this is also a placental abnormality. So this is the uterus. Suppose outer layer of the uterus, this one is the middle layer and this one is the internal layer of uterus. So this one is the endometrium, this one is the myometrium, layer of the uterus, and this one is the serosa, perimetrium, layer of the uterus. Normally placental villi attached to the endometrial layer of the uterus, but due to absence of which layer? Due to absence of 𝗘𝗱𝗶𝗁𝗍 layer, placental villi will attach, so this is the endometrium, will attach superficially to the myometrial layer of the uterus. Superficially attached to the myometrial layer of the uterus. So this is called as placenta Accreta. Superficially attachment of placental villi to the myometrial layer. But if they penetrate into the myometrium, then this is called as placenta increta. Placenta increta. But if placenta villi attached to the outer layer of the uterus, outer layer, serosa of the uterus, so this is called as Accreta. Placenta Accreta. So clear? Accreta, superficial attachment to the myometrium. Increta, villi will invade the myometrium. Accreta means par, uterus ke par chala gaya. Serosa of the uterus. So in this condition, it will be difficult to remove the placenta. So treatment, first of all, investigation of choice. In this case, 3D ultrasound Doppler. Presentation of the patient, persistent persistent vaginal bleeding or postpartum hemorrhage. Postpartum hemorrhage. Postpartum hemorrhage. So this is a placenta accreta. Now moving toward next topic, that is amniotic fluid. So first of all, source of amniotic fluid. In first trimester, so what is the source of amniotic fluid? Source of amniotic fluid in first trimester. So in first trimester, source of amniotic fluid is ultrafiltration from maternal plasma. Ultrafiltration from maternal plasma. After 12 to 20 weeks, main source diffusion from fetal skin. After 20 weeks, after 20 weeks, the main source of amniotic fluid is fetal urine. Clear? So fetal kidney become functional at around after 12 weeks of pregnancy. After 12 weeks of pregnancy. So this is the PYQ. Amount of liquor is maximum 1000 ml at. Amount of liquor maximum amniotic fluid. But at 12 weeks of pregnancy, amniotic fluid amount is around 50 ml. At 20 weeks, 400 ml. 32 to 34 weeks, 1000 ml. So maximum at around 32 to 34 weeks. So at term around 800 ml. And at post-term pregnancy, 200 ml. So this is the amount of amniotic fluid according to gestation. So maximum at around 32 to 34 weeks of pregnancy. So measurement of amniotic fluid, investigation of choice, ultrasound. Suppose this is the abdomen. Divide this into 4 parts, A, B, C, D. Now we have to measure largest deep pocket. Abdomen divided into 4 quadrants. So there are 2 parameters, AFI and SDP. AFI means amniotic fluid index. So we have to add A plus B plus C plus D. Largest vertical pocket of amniotic fluid. Then we will get this value, amniotic fluid index. Second one, SDP, single deep pocket. Single deep pocket means largest single deep pocket. So we have 2 parameters, amniotic fluid index and SDP. So oligohydramnios and polyhydramnios. These are amniotic fluid disorders. So normal value of AFI is around 5 to 25 centimeters. And single deep pocket 2 to 8 centimeters. If AFI is less than 5 centimeters, single deep pocket is less than 2 centimeters, this is called as oligohydramnios. In case of polyhydramnios, AFI more than 25 centimeters, single deep pocket more than 8 centimeters is called as polyhydramnios. Again, in case of oligohydramnios, if the volume of amniotic fluid is less than 200 ml, or in case of polyhydramnios, more than 2000 ml. Fundal height less than period of gestation. In case of poly, more than period of gestation. So these both conditions are amniotic fluid disorder. So we can diagnose oligohydramnios if AFI is less than 5 centimeters, single deep pocket less than 2 centimeters, volume less than 200 ml, and height of the uterus less than period of gestation. POG means period of gestation. Or in case of poly, AFI more than 25 centimeters, single deep pocket more than 5 centimeters, more than 8 centimeters, volume more than 2000 ml, and height of the uterus more than period of gestation. So this is a PYQ. Most common cause of oligohydramnios. Renal agenesis. Renal agenesis is the most common cause of oligohydramnios. What is the most common cause of polyhydramnios? Congenital GIT anomalies. Congenital GIT anomalies. Okay. So what are the causes of both polyhydramnios and oligohydramnios? It's seen in torch infections and twin-to-twin transfusion syndrome. Torch infection means toxoplasmosis, other means syphilis, rubella, CMV, cytomegalovirus, herpes simplex virus, and twin-to-twin transfusion syndrome. Okay, clear? Now, a labor is induced at 38 weeks of gestation due to severe oligohydramnios. Amniotic fluid less than 200 ml. And the infant is born with congenital absence of the left hand. This is likely due to which of the following? Amniotic band, genetic abnormality, true nodes, and maternal trauma. Yes? Okay, tell me what are the complications of severe oligohydramnios? Just remember the name of 3 syndromes. First one, amniotic band syndrome, or you can say Preterm syndrome. Constriction band syndrome. This is the first syndrome in case of severe oligohydramnios. Second one, meconium aspiration syndrome. Meconium aspiration syndrome. And third one, Porter's syndrome. Porter syndrome. So all these syndromes are associated with severe oligohydramnios. So the right answer here, amniotic band syndrome. In case of severe oligohydramnios, sometimes at the time of rupture of membranes, suppose there is a premature rupture of membranes, then the fetal membranes will stick around the fetal parts in the form of band, which will cause devascularization of that part. This is called as amniotic band syndrome. Remember these 3 syndromes: amniotic band syndrome, meconium aspiration syndrome, and Porter's syndrome. Clear? Now, very important topic for FMGE exam, prenatal aneuploidy screening. So this should be done in all pregnant females in first trimester. First trimester between 11 to 13 weeks. Double marker test. What are double marker test? Beta-HCG plus PAP-A. PAP-A, pregnancy associated plasma protein A. Pregnancy associated plasma protein A. Plasma protein A. So these are called as double marker test. Plus ultrasound. So ultrasound, we have to check knuckle translucency and nasal bone. Plus nasal bone. Normally we do screening especially for Down syndrome. So there are other syndromes also, but we are doing especially for Down syndrome. Why? Because trisomy 21 is a most viable trisomy. Chances of abortions are only 30%. But in case of trisomy 18, in case of adverse syndrome, monosomy, the chances of abortion is around 85 to 90%. So they get aborted. So that's why screening for Down syndrome is very, very important. So in ultrasound, we have to check first of all nasal bone. So nasal bone is absent in Down syndrome. Secondly, we have to check this part at the nape of the neck. This is called as knuckle translucency, this part. So normal thickness should be less than 3 mm. Normal thickness of knuckle translucency should be less than 3 mm. If it is more than and equal to 3 mm, it means there is a problem. What is the most common cause? First of all, Down syndrome. First of all, Down syndrome, then Turner's syndrome, then Turner's syndrome. Next step, we have to do karyotyping. Karyotyping. But if karyotyping is normal, then what is the next step? If karyotyping is normal, then we have to do echocardiography. Echocardiography of fetus at around 22 to 24 weeks of gestation. 22 to 24 weeks of gestation. Because the other cause could be congenital fetal heart anomalies. Fetal heart anomalies and fetal heart defects. So these are the first trimester test. Ultrasound and dual markers, collectively called as combined test. So now let's discuss about second trimester test. Second trimester between 16 to 18 weeks. So what are triple marker test? Maternal serum alpha fetoprotein, Beta-HCG, and unconjugate estriol, E3. These are called as triple marker test. Quadruple, just add inhibin A. Just add inhibin A. So these are called as quadruple test. So what are integrated test? Integrated test. So these are combined test of first trimester plus quadruple test. So these are second trimester test. Fluid filled area extending downwards, not restricted to neck. So this is called as cystic hygroma. If detected in first trimester, then the cause could be Down syndrome. But if detected in second trimester, then the cause could be Turner's syndrome. So this is a cystic hygroma. So next topic, best screening test for Down syndrome. So best screening test for Down syndrome is non-invasive prenatal testing. This is called as non-invasive prenatal testing. So this is a secondary screening test for Down syndrome, done at around 10 weeks onward. So we can done this test after 10 weeks of pregnancy. Sample maternal serum. Maternal serum. So analysis, cell-free fetal DNA. Cell-free fetal DNA. Sensitivity is around 99%. 99%. So this is the best test for the screening of Down syndrome. Sensitivity is 99%. But this test is very, very expensive. Cost is around 14 to 16,000. This test is very, very expensive. Okay, so this is all about screening for Down syndrome. Now, answer this question. 36-year-old preemie, 12 weeks pregnant, found to have increased risk of trisomy 21. So, she wishes to have further testing to confirm whether the fetus is affected or not. So, what is the best diagnostic test in current situation? She is 12 weeks pregnant. So, the right answer, chorionic villus sampling. So, what are the diagnostic tests for Down syndrome? Chorionic villi sampling, amniocentesis and chordocentesis. What is the time to do chorionic villi sampling? Time at around 10 to 14 weeks in first trimester, chorionic villi sampling. So, we have to test for, yes, 10 to 13, 10 to 14. Trophoblast. Sample trophoblast. Ultrasound guided. So, timing for amniocentesis, timing to do amniocentesis, yes, after 15 weeks to 20 weeks of gestation. And chordocentesis after 18 weeks onward. We can do chordocentesis in second trimester. So, chorionic villi sampling in first trimester, amniocentesis in second trimester, and chordocentesis in second trimester. So, these are the diagnostic tests for Down syndrome. Clear? So, now next. So, next topic is fetal surveillance, NST and CTG. So, NST is done for antepartum fetal heart rate monitoring. Please remember this point. Now, so NST is done for antepartum fetal heart rate monitoring. Antepartum means during pregnancy. So, CTG is done for intrapartum fetal heart rate monitoring. So, NST when the patient is not in labor, CTG when the patient is in labor. So, this is the difference between NST and CTG. Now, first of all, let's talk about non-stress test. So, non-stress test done after 32 weeks onward. 32 weeks onwards. Important one is what are the components of NST. So, first of all, fetal heart rate. So, normal fetal heart rate 110 to 160 beats per minute. BMP means beats per minute. Less than 110 is called as bradycardia. More than 160 is called as tachycardia. So, normally we do non-stress test for fetal heart monitoring in case of high risk pregnancy. So, first component fetal heart rate. Second component beat to beat variability. So, fetal heart rate is not constant. ये कैसा रहेगा? इन ए zigzag pattern. Look at this image. Zigzag pattern of fetal heart rate in a zigzag form. So fetal heart rate is not constant. Fetal heart rate is variable by 5 to 20 beats per minute. So there is a variation of 5 to 25 beats per minute, which indicates that the fetal is healthy. So this is a healthy fetus. Beat to beat variability. So absent variability or less than 5 beats per minute, this indicates fetal hypoxia or fetal distress. Clear? So this one is the second component. Third component, fetal acceleration. So what is the meaning of fetal acceleration? While fetal movements, fetal heart rate increases by 15 beats per minute for 15 seconds. 15 beats per minute for 15 seconds. This is called as fetal acceleration. Okay, now, so these are the three components. Please remember fetal heart rate, beat to beat variability and fetal acceleration. Now, what is the meaning of sinusoidal wave pattern? Pattern indicates fetal anemia. So fetal anemia is seen in which condition? Fetal anemia in case of vasa previa. In case of RH incompatibility. In case of parvovirus B19, fetal anemia. So sinusoidal wave pattern means heart rate like this. This is called as sinusoidal wave pattern. You can see sinusoidal in case of fetal acidosis. In case of severe hypoxia. चलो अब नेक्स्ट देखें. So what is the meaning of reactive NST? It means at least more than equal to 2 accelerations, each acceleration in 20 minutes with duration of at least more than equal to 2 accelerations, each acceleration in 20 minutes with duration of 15 seconds by at least 15 beats per minute. So this is called as reactive NST. If non-reactive, then we have to repeat NST for 20 minutes. Again for 20 minutes. If again non-reactive, then next step. So what is the next step? In case of non-reactive NST for total 40 minutes, we are getting non-reactive NST, the duration of 40 minutes. Then what is the next step? So next step is BPS, Biophysical score. This is the next step, Biophysical score. So what are the components of biophysical scoring? So this is the PYQ. So I have marked as a PYQ on every previous year questions. So what are the components of biophysical score? Just remember the mnemonic Batman. So देखते हैं components of biophysical score. So it is done by ultrasound under 30 minutes. So first of all, it is also called as Manning score. So first of all, As I told you, mnemonic is Batman. So first, fetal breathing movement. Fetal breathing movement, more than one episode of fetal breathing for more than 30 seconds. More than 30 seconds. A means amniotic fluid. So single deep pocket amniotic fluid should be more than 2 cm. More than 2 cm. And fetal tone. T means tone, more than equal to one episode of fetal extension and flexion in 30 minutes. Gross fetal body movements, more than 3 fetal body movements in 30 minutes, and non-stressed test reactive. So these are the components of biophysical score. Just remember the mnemonic BAT. B stands for breathing, A stands for amniotic fluid, T means fetal tone, again M means movements, N means non-stress test. It should be reactive. So total scoring is about 10. NST is done after 32 weeks. Because after 32 weeks, there is a functioning of autosomal nervous system of the baby. So this is all about NST and biophysical scoring. If score is around 8 out of 10 or 10 out of 10, it means healthy fetus. There is a no problem. If 6 out of 10, then we have to again do reassessment for 24 hours. If less than 6, it means there is a severe fetal hypoxia. And treatment is termination of pregnancy. Now, let's talk about CTG, cardiotocography. So, CTG is done when the patient is in labor, because labor is a very stressful condition. So what is the meaning of deceleration? Deceleration means sudden fall in fetal heart rate by 15 beats per minute for 15 seconds. This is called as deceleration. Sudden fall in fetal heart rate by 15 beats per minute for 15 seconds during uterine contractions. Clear the meaning of deceleration? Now, types of deceleration. This point is very, very important. Types of deceleration. So, what is the meaning of early deceleration? So, there are 3 types: early, late, and variable. So, first of all, early deceleration. So, look at this graph. So, there are 2 graphs in CTG. Upper one is for fetal heart rate, lower one is for uterine contractions. Fetal heart rate and uterine contractions. So, early deceleration means fall in fetal heart rate. Fetal heart rate drops. This is a fetal heart rate. Fetal heart rate drops with the onset of uterine contraction. Drop in fetal heart rate with the onset of uterine contraction. This is called as early deceleration. Fetal heart rate drops with the onset of uterine contraction. Contraction over, fetal heart rate returns to normal. Deceleration means uterine contraction, during uterine contraction. So, NST is done during antepartum period. Okay, and CTG is done during intrapartum. So when the patient is in labor. Okay, early deceleration is seen in head compression. Head compression. So which is normal during labor. Physiological. Physiological. So we can wait and watch. Just wait and watch. Seen in head compression. Now, next one. So fetal heart rate starts falling. Please look at this point. Fetal heart rate starts falling on the peak of uterine contraction. So this is the peak of uterine contraction. This is called as late deceleration. Late deceleration. Fetal heart rate starts falling at the peak of uterine contraction. Uterine contraction. What is the cause of late deceleration? Okay, so the cause is placental insufficiency. Insufficiency is the cause of late deceleration. It means there is a fetal hypoxia. Fetal hypoxia. So what is the treatment? Cesarean section. In case of fetal distress, cesarean section. So this is a type 2. Now, variable deceleration, there is a no pattern. There is a no pattern between fetal heart rate and uterine contraction. Means no regular pattern between fetal heart rate and uterine contraction. Means there is a sudden fall in fetal heart rate. Fetal heart rate. So what is the cause of variable deceleration? The cause is cord compression. Cord compression. The cord compression is seen in which condition? Seen in which condition? In case of severe oligohydramnios. In case of severe oligohydramnios, or in case of post-term pregnancy. Post-term pregnancy. So this is a variable deceleration. Clear? Clear? Very important topic. Ectopic pregnancy. Very, very important. If the implantation of blastocyst occurs outside the uterine cavity, this is called as ectopic pregnancy. So what is the most common site? ये तो tips पे होगा ना सबके. What is the most common site of ectopic pregnancy? Modified biophysical score means there are only two parameters, NST and AFI. Modified BPS. Only two parameters, NST plus AFI. This is called as modified BPS. So most common site, ampulla of fallopian tube. Ampulla of fallopian tube is the most common site for fertilization, most common site of ectopic pregnancy. So tubal ectopic pregnancy with the longest survival. So ectopic pregnancy can occur anywhere. Anywhere. Uterus, outside the uterus, fallopian tubes, interstitial part of the tube, isthmus, infundibulum, abdominal, ovaries. Least common site is the ovaries, 0.5% chances. So tubal ectopic with longest survival. Intramural, or you can say interstitial. This part of the fallopian tube. This area is the longest survival, up to 12 weeks. Ectopic pregnancy at the site of interstitial can survive up to 12 weeks. and rupture can lead to massive bleeding. Massive bleeding. So this is the most dangerous site of ectopic pregnancy. Most dangerous site of ectopic pregnancy. So where is the maximum survival of ectopic pregnancy? Non-tubal. I'm asking non-tubal. Maximum survival. Non-tubal. Non-tubal site, abdominal. Abdominal ectopic. Ectopic. Okay. So outcome of ectopic pregnancy. What is the outcome of ectopic pregnancy? Tubal abortion. There could be tubal abortion and tubal rupture. Tubal rupture. Tubal abortion, tubal rupture. Outcome of ectopic pregnancy. So what is the most common risk factor? See, there is a difference between risk factor and most common cause. So most common cause is PID, pelvic inflammatory disease. Most common cause is pelvic inflammatory disease. Now tell me, what is the most common risk factor for ectopic pregnancy? Risk factor is history of ectopic. History of ectopic pregnancy is the most common risk factor. If there is a history of one ectopic pregnancy, then the chances will be high up to 15% in next pregnancy. If there is a history of 2 ectopic pregnancies, then in next pregnancy chances are about 30%. The most common risk factor is history of ectopic pregnancy, and second most common risk factor is tubal surgeries. Tubal surgeries, because of there is a formation of adhesions. Tubal surgeries. Now, clinical presentation of ectopic pregnancy. Clinical presentation. So in case of ectopic pregnancy, patient will come first of all with complaint of bleeding per vagina. Secondly, pain abdomen, and third one, amenorrhea. So this is the clinical presentation of ectopic pregnancy. Ectopic pregnancy is of 2 types, ruptured and unruptured. So this is a clinical presentation. In case of unruptured ectopic pregnancy, there could be a ruptured, but in case of ruptured, patient will come with complaint of severe pain abdomen, with hypotension, with tachycardia, with the features of shock. So bleeding PV, second one, pain abdomen due to stretching of the tube, and amenorrhea. So whenever patient come with these symptoms, first step is to do UPT, urine pregnancy test. 98% cases में positive है. UPT, urine pregnancy test. So if we talk about investigations, first investigation is UPT, urine pregnancy test. Investigation of choice, ultrasound, TVS, and the gold standard investigation is laparoscopy. Laparoscopy is a gold standard. So on ultrasound, first sign of ectopic pregnancy. So what is the first sign of ectopic pregnancy on ultrasound? Empty uterus. Empty uterus. No gestational sac. Empty uterus is the first sign of ectopic pregnancy on ultrasound. Now, second sign, yes, on Doppler you will see the ring of fire appearance because of high vascularity of that mass. high vascularity. So second sign, gestational sac, GS means gestational sac without yolk sac and cardiac activity. It could be present or not, okay. And the site is fallopian tube, fallopian tube. This is the second sign of ectopic pregnancy on ultrasound. Gestational sac without yolk sac with cardiac activity could be present or not. Site is fallopian tube. On ultrasound Doppler, you will see the ring of fire appearance because of high vascularity. So clear? Now, what is the treatment of ruptured ectopic pregnancy? So this is also PYQ. What is the treatment of ruptured ectopic pregnancy? First of all, immediate resuscitation. Then best management is only surgery. Removal of fallopian tube. Fallopian tube. Both tubes are unilateral. Removal of fallopian tube is called as salpingectomy. So we have to do unilateral salpingectomy. Salpingectomy. If the vitals of the patient are stable, then we can do laparoscopy. If unstable, then laparotomy. Best management in case of ruptured ectopic pregnancy. So management of unruptured ectopic pregnancy. So we can do conservative management and surgical. See, if the vitals are stable, patient is motivated, compliant, Beta-HCG levels less than 5,000 international unit, sac size is less than 4 cm, cardiac activity absent, then drug of choice. Drug of choice, methotrexate. Methotrexate is the drug of choice. So this is a conservative management of unruptured ectopic pregnancy. तो ruptured में हमेशा ट्यूब को निकालना है. In case of unruptured, we can do conservative management and surgical. So methotrexate with the dose of 50 milligrams meter square on day 1. Then we have to check the Beta-HCG levels on day 4 and day 7. So surgical management, if the family is complete, then unilateral salpingectomy. If the family is not complete, then we have to do linear salpingostomy. Suppose this is a ectopic pregnancy, just give a incision here, linear salpingostomy. With hydrodissection, remove the product of conception, then leave this area open. No suture required. Leave this area open. So this is called as linear salpingostomy. So this is all about ectopic pregnancy. Moving toward next topic, gestational trophoblastic disease. This is also very important. Gestational trophoblastic disease. So there are two types of gestational trophoblastic disease. So this is a disease of trophoblast. So first of all, molar pregnancy. Second one, gestational trophoblastic neoplasia. Have to check Beta-HCG levels between day 4 and day 7. If less than 15%, then we can say our treatment is successful. If there is a no fall in beta-HCG levels, then we have to give again injection methotrexate. Means we can give maximum 3 doses of methotrexate. If it fails, then next step is surgical intervention. Okay, now molar pregnancy, 2 types, partial mole and complete mole. Gestational trophoblastic neoplasia are 4 types. First one, invasive mole, choriocarcinoma. Third one, PSTT, placental site trophoblastic tumors. Fourth one, epithelioid trophoblastic tumors. So what is the meaning of molar pregnancy? So this is not a viable pregnancy. It means in molar pregnancy, there is a excessive proliferation, abnormal excessive proliferation of trophoblast. And these trophoblasts fill up the entire uterus with hydropic degeneration. Okay, this is a molar pregnancy. 2 types, partial mole and complete mole. So molar pregnancy is a benign trophoblastic disease, but it can be malignant. Otherwise, molar pregnancy is a benign condition. So this one is a benign. Neoplasia means, GTN means malignant. 4 types, invasive mole, choriocarcinoma, placental site trophoblastic tumors and epithelioid trophoblastic tumors. Now, what is the difference between partial mole and complete mole? So in partial mole, basically there is a wrong fertilization, wrong placentation. So in partial mole, this is a dispermic, means one female ova is fertilized by 2 sperms. So this is called as dispermic. Triploid, karyotyping triploid, 69XXY. There could be a 69XXX. So this is a partial mole. Complete mole, monospermic, only 1 ova which is empty. Female chromosomal, these are not activated. Empty ova is fertilized by a single sperm. So complete mole is a monospermic. Diploid, 46XX. So there is a duplication of chromosomal numbers, 46XX. Clear? Now, what is the presentation of molar pregnancy? So first of all, patient will come, yes, partial mole, P57 will be present. Yes. So presentation, first of all, patient will come with complaint of bleeding per vaginum in early pregnancy. So what are the causes of bleeding in early pregnancy? Causes of bleeding in early pregnancy. What is the most common cause of bleeding in early pregnancy? Most common cause, abortion. Second one, ectopic pregnancy. Third one, molar pregnancy. Just remember these 3: abortions, ectopic pregnancy and molar pregnancy. So now, come to the point, presentation of molar pregnancy, bleeding per vaginal early pregnancy. Sometimes passage of grape-like vesicles. Due to undue proliferation of ट्रोफोब्लास्ट, ट्रोफोब्लास्ट, ये सब क्लियर है ना आपको? ट्रोफोब्लास्ट, तो ब्लास्टोसिस्ट, outer layer is called as trophoblast, inner layer is called as inner cell mass. Then on day 8 after fertilization, trophoblast is divided into cytotrophoblast and syncytotrophoblast. Okay, so undue proliferation of trophoblast. So which hormone is secreted by syncytotrophoblast? First hormone in pregnancy secreted by syncytotrophoblast. What is the name of that hormone? First hormone in pregnancy secreted by syncytotrophoblast. So as I told you, molar pregnancy is a abnormal proliferation of trophoblast, means excessive trophoblast. Suppose this is the uterus, this is the uterine cavity. Okay, now there is a number of trophoblasts filling up the entire uterus, filling up the entire uterus. More trophoblast means more number of beta-HCG. So beta-HCG is a hormone which is responsible for vomiting in pregnancy. So high beta-HCG means hyperemesis gravidarum, hyperemesis gravidarum, excessive vomitings. So HCG has two units, alpha subunit and beta subunit. So the alpha subunit of HCG is equal to, similar to TSH, LH and FSH. TSH, follicular stimulating hormone, and luteinizing hormone. So it will act like a LH and TSH also. So patient will have hyperthyroidism, hyperthyroidism, thyrotoxicosis, and because of LH, bilateral theca lutein cyst, ovarian cyst. A patient will have pregnancy-induced hypertension in early pregnancy. Period of gestation will be more, height of the uterus will be more, than the period of gestation. Doughy abdomen. So this is a presentation of molar pregnancy. So investigation of choice in molar pregnancy, first step is ultrasound. Gold standard, histopathological examination. So this is the most favorite ultrasound image, most favorite. Snowstorm appearance. Contraceptive of choice in molar pregnancies, OCPs, oral contraceptive pills. This is the most favorite ultrasound image, snowstorm appearance, which is seen in complete mole. This is a PYQ, snowstorm appearance, in complete mole, and fetal parts are absent in complete mole. So in case of partial mole, you will see cystic placenta. So this is a cystic placenta, some fetal parts present. So sometimes diagnosed as a missed abortion. And transverse diameter of gestational sac will be raised. Transverse diameter of the gestational sac will be raised in case of partial mole. In case of partial mole. So this is the ultrasound picture. First one is the complete mole, second one for partial mole. So this is the important part, management of molar pregnancy. So what is the management of molar pregnancy? Management of molar pregnancy, suction and evacuation. Suction and evacuation. Evacuation is the treatment of molar pregnancy. What in case of thecal lutein cyst? What is the treatment? Thecal lutein cyst. No treatment is required because after suction and evacuation, thecal lutein cyst, they will resolve automatically after 2 to 3 months. 2 to 3 months of evacuation. No treatment required. Follow-up. Follow-up is important because of risk of GTN. So as I told you, molar pregnancy is a benign trophoblastic disease, but malignancy can be occur. Follow-up is important. So check beta-HCG levels till 6 months. Till 6 months, pregnancy is contraindicated. Contraindicated. Because we have to check the beta-HCG levels till 6 months. So pregnancy is contraindicated. Contraception of choice, OCPs, oral contraceptive pills, OCPs. So what about IUCD, intrauterine contraceptive device? This is also contraindicated. Contraindicated. Because it can cause uterine rupture. Uterine rupture. Most common site of metastasis of choriocarcinoma is lungs. Lungs. Phagostaging of GTN. Stage 1 limited to uterus. Limited to uterus. Stage 2 involvement of pelvic and vagina. Stage 3 involvement of lungs. Stage 4 brain metastasis. Brain metastasis. Here this is a phagostaging of GTN. So most common appearance on chest X-ray in case of choriocarcinoma metastasis. Yes, cannonball appearance. Cannonball appearance. Cannonball appearance. Chest X-ray. Choriocarcinoma. Cannonball appearance. And second most common appearance. What is the second most common appearance? In case of metastasis, choriocarcinoma metastasis in lungs. Second most common appearance is snowstorm appearance. Snowstorm appearance on chest. Snowstorm appearance on chest X-ray. Clear? Snowstorm appearance on ultrasound is seen in complete mole. On chest X-ray is seen in metastasis of choriocarcinoma in lungs. Clear? Now, management of GTN. So, management is divided into some scoring system. If the score is less than 6, it means low risk GTN. Then the drug of choice, methotrexate. Methotrexate is the drug of choice. On day 1, day 3, day 5 and day 7. Multi-dose methotrexate with alternate with folinic acid. Alternate with folinic acid. In case of high risk, if the scoring is more than equal to 7. Then IMACO regime. In case of GTN, you can say Bagshaw regime. Etoposide, methotrexate, actinomycin D, cyclophosphamide and oncovin in case of high risk GTN. Clear? Low risk means if the scoring is less than 6, high risk means if the scoring is more than 7. So next topic is abortion. Abortion means pregnancy loss before 20 weeks of gestation. This is called as abortion. WHO definition: expulsion and extraction of fetus weight less than 500 grams. So what is the most common cause of abortion? Most common cause of abortion: aneuploidy. Aneuploidy. Then trisomy, then monosomy, then trisomy 16. Most common cause of abortion. So 95% of chromosomal defects are due to 95% chromosomal defects are mainly due to advanced maternal age, poor egg quality, because of advanced maternal age, more than 35 years of age, So 3 types of abortion: spontaneous abortion, or you can say isolated. Second one, recurrent abortions. Third one, induced. Induced means MTP. So these are the types of spontaneous abortion. 5 types: threatened abortion, inevitable abortion, incomplete, complete and missed. Okay, so let's see one by one. Threatened abortion is reversible. Symptoms: spotting per vagina. Internal O's closed, will be closed. On ultrasound, cardiac activity present. Trisomy 16, what happened exactly? Actually, trisomy 16, abortion chances are about 85 to 90% among all the trisomies. Okay. Now, inevitable is irreversible. Means the process of abortion has started, but we can't continue this pregnancy. Irreversible: bleeding present, abdominal pain present, internal O's will be open in case of inevitable abortion. Cardiac activity absent on ultrasound. Complete, incomplete: product of conception start to come out, but the process is incomplete. This is called as incomplete abortion. Bleeding, pain abdomen and internal O's will be open. On ultrasound, you will see incomplete product of conception inside the uterus. So this is a incomplete abortion. So in case of complete, product of conception expelled. So symptoms: history of bleeding and pain, but at present no bleeding. Internal O's closed and uterus empty uterus. So this is a complete abortion. Missed abortion remained unnoticed. Means female is not aware of missed abortion. Symptoms: sometime brownish colored brownish colored vaginal discharge. Vaginal discharge, internal os closed. Internal os closed in case of missed abortion. So what is the ultrasound definition of missed abortion? If the mean sac diameter is more than 25, round rump length is more than 7, cardiac activity is absent. So this is the ultrasound definition of missed abortion. Definition of missed abortion. So these are types of spontaneous abortion. Spontaneous abortion. This is called as belated ovum. Unembryonic pregnancy. So these are one-liners. Most common cause of second trimester recurrent abortion. So most common cause of second trimester recurrent abortion. Cervical incompetence. Cervical incompetence is the most common cause of recurrent abortion. Recurrent abortion means more than and equal to 3 pregnancy loss. Consecutive 3 pregnancy losses. This is called as recurrent abortion. The most common cause, cervical incompetence. It means short cervix. Short cervix. Length of the cervix less than 2.5 centimeters. Short cervix. So most common uterine anomaly associated with abortion. Septate uterus. Septate uterus, then bicornuate uterus. Septate uterus, then bicornuate uterus. So what is the single most cause of recurrent abortion? Single most cause of recurrent abortion. Apla syndrome. Antiphospholipid antibodies. So this is the one of the most single cause of recurrent abortion. Antibodies are formed against phospholipids which are present on cell membrane. Present on cell membrane. Apla syndrome, there is a formation of 3 types of antibodies. First one, lupus anticoagulant antibody, anti-cardiolipin antibody, anti-beta-2 glycoprotein antibody. So these are the main 3 antibodies which are present in Apla syndrome. Basically, Apla syndrome is a hypercoagulate state. Formation of thrombosis. Thrombosis formation in arteries, veins, placental sites, spiral arteries, formation of thrombosis. This is a Apla syndrome. If there are more than 2 pregnancy losses, then we have to do investigations. 2 pregnancy losses. Now, in Apla syndrome, there is a formation of thrombosis in arteries, veins and placental vessels, mainly spiral arteries, which can lead to abortion in early stage, uteroplacental insufficiency, early onset of preeclampsia. Preeclampsia, IUGR, intrauterine growth retardation and intrauterine fetal demise. These are the complications which are associated with Apla syndrome. So diagnosis. So what is the criteria for the diagnosis of Apla syndrome? So modified, yes, okay, modified Furrow criteria. Management. What is the management? Formation of thrombosis. Arteries, veins, spiral arteries, placenta, everywhere. What is the management of Apla syndrome? as soon as pregnancy is diagnosed, start tablet aspirin with the dose of 75 to 100 milligram OD. OD means once in a day. As soon as pregnancy is diagnosed. Pregnancy is diagnosed. Then injection low molecular weight heparin. Low molecular weight heparin till 37 weeks of gestation. Means we have to give this injection subcutaneously daily till 37 weeks of pregnancy. When to start? When the cardiac activity is present. Cardiac activity is present. Then we have to start injection low molecular weight heparin till 37 weeks of pregnancy. So this is a treatment of APLA syndrome. APLA syndrome. So now MTP, medical termination of pregnancy. New Act and old. According to new Act, MTP can be done up to 24 weeks of gestation. Up to 24 weeks of gestation. In case of fetal anomaly, 24 weeks. No upper limits. No upper limits. Single doctor opinion up to 20 weeks. Two doctors opinion up to 20 to 24 weeks. These are the MTP recommendations according to new Act. According to new Act. MTP can be done up to 24 weeks. If there are fetal anomalies, then no upper limits. Normally up to 24 weeks, but no upper limits. Single doctor opinion up to 20 weeks and two doctor opinions up to 20 to 24 weeks of gestation. So indications of MTP in case of rape victim, in case of fetal anomalies, in case of contraceptive failure, in case of mother and fetus, both are in risk. These are the indications of MTP. In case of, if period of gestation is more than 24 weeks, then we can do MTP if anomalies are present, only after approval of a medical board. If we talk about the consent, if the age of the female is more than 18 years, then there is no need of partner consent. If less than 18 years or if she is mentally retarded, then guardian's consent are important. So medical board is a consist of gynecologist, radiologist, pediatrician and a person assigned by state. So group of 4. This is a group of 4. Gynecologist, radiologist, pediatrician and a person assigned by state. This is very important. MTP, abortions, एक क्वेश्चन तो पक्का ही है, एक से भी ज़्यादा. Abortions and MTP. Next one, PYQ, medical abortion in first trimester. Medical abortion in first trimester. First day, what is the drug? Tablet mifepristone. Mifepristone with the dose of 200 milligrams orally. With the dose of mifepristone 200 milligrams orally, and day 2 tablet misoprostol 800 microgram vaginally. So what is the action of mifepristone? So mifepristone is a anti-progestin drug. So it will detach the implanted embryo. Okay, and mesoprost. Mesoprost will expel the fetus, expel the embryo. Okay, so this is a first trimester abortion, medical abortion. Surgical suction and evacuation can be done from 9 to 12 weeks of gestation. We can do till 16, but 9 to 12 weeks of gestation. By using Karman cannula, MVA syringe and ovum forceps. So this one is a Karman cannula. Number of the Karman cannula corresponds to period of gestation. If 8 weeks pregnancy, then we will use 8 number of Karman cannula. MVA syringe, manual vacuum aspiration syringe. So Karman cannula is attached to suction machine. But in some areas, if electricity is not available, then we can use MVA syringe. MVA syringe with the volume of 60 ml and pressure is around 660 mm of Hg. On this one is the ovum forceps, oval in shape. Medical abortion and surgical abortion in first trimester. In case bubbles are present, it means abortion is completed. Your process of evacuation is completed. If bubbles are present and grasping effect of uterus, it means the abortion and the evacuation is completed. Okay. Now, in second trimester, best method is the use of prostaglandins. Prostaglandin, E1 misoprostol with the dose of 400 microgram 4 hourly vaginally, maximum doses up to 5. Prostaglandin E2 is a dinoprost, vaginal gel form. Prostaglandin F2 alpha is a carboprost, intramuscular only. Next, amniotic, these are outdated now. Most commonly used prostaglandins. Misoprost 400 micrograms 4 hourly, vaginally, maximum doses up to 5. Dinoprost in the form of vaginal gel and carboprost. So this is a medical abortion in second trimester. Dilatation and curettage. We can do up till 16 weeks of gestation. Next topic, antepartum hemorrhage. Very important. इसमें तो आपका क्वेश्चन पक्का ही है. Very important topic, antepartum hemorrhage. So what is the meaning of antepartum hemorrhage? So antepartum hemorrhage means if bleeding occurs in the genital area of the female in third trimester, means bleeding after 28 weeks of pregnancy, bleeding in third trimester, bleeding after the period of viability. So this is called as antepartum hemorrhage. The most common cause of antepartum hemorrhage, abruptio placenta. And the second most common cause of antepartum hemorrhage, placenta previa. And the other causes like vasa previa. So most common cause is abruptio placenta. Second most common cause is placenta previa. So placenta previa means if the placenta implants partially and completely over the lower segment of the uterus. That is called as placenta previa. Now tell me, what are the causes of placenta previa? Risk factors are same: multiparity, increased maternal age, advanced maternal age, history of antepartum hemorrhage. These are the risk factors. Now tell me what are the causes of placenta previa. First of all, big placenta. Big placenta is a cause of placenta previa. Big placenta in case of twin pregnancy. Big placenta in case of polyhydramnios. Twin pregnancy, polyhydramnios, accentuate lobe of placenta, bilobata placenta. So, big placenta is a cause. Second cause is defective endometrium. If there is a history of myomectomy, uterine history of surgery, history of cesarean, so all these are the causes of placenta previa. Now, these are the types of placenta previa. Type 1, type 2, type 3 and type 4. So, type 1 is a low-lying placenta. Means placental edge are present within 2 cm from internal oats. This is called as low-lying placenta. So, edge is within 2 cm of internal oats. This is called as low-lying placenta. So, marginal placenta, edges are touching the internal oats. Edges touch internal oats. Partial placenta previa means partially covering the internal oats. Complete means completely covering the internal oats. This is a complete placenta previa. Complete placenta previa. So, 4 types. So, this is an old classification of placenta previa. New classification, there are 2 types. Low-lying placenta, edges within the 2 cm of internal oats. Second one is the placenta previa, partially and completely covering the internal oats. So, next one, abruptio placenta. So, what is the meaning of abruptio? It means placenta is located normally, but it separates prematurely. This is called as abruptio placenta. So, there are 3 types of abruptio placenta. Revealed, concealed and mixed. Revealed, concealed and mixed. So, in this case, look at this first image. After separation of placenta, blood gets space to come out. Bleeding is visible. So, this is called as revealed placenta, abruptio placenta. Revealed. This is a revealed type of abruptio placenta. Bleeding is visible. Second one, concealed. So, this is a concealed type. After placental separation, blood will start collecting behind the placenta. Bleeding is not visible. So, this is called as concealed. Concealed means conceal हो गया है, seal हो गया है. So, this is a concealed hemorrhage. Retroplacental clots. Okay. So, revealed, concealed and mixed is most common. In case of mixed, bleeding will be there plus retroplacental clot. Bleeding will be there plus retroplacental clot. Retroplacental clots. So, 3 types of abruptio placenta. So, sometimes blood which is collecting behind the placenta, in case of concealed placenta. abruptio placenta. AP means concealed abruptio placenta. So sometimes blood collects behind the placenta, and this blood enters into the myometrium layer of the uterus. Myometrium layer of uterus. So there is a term covular uterus. This is a covular uterus. Appearance of uterus, wine and bluish colored uterus. Bluish colored uterus. So this is a case of covular uterus. Covular uterus. So it is not a indication for an hysterectomy. Hysterectomy नहीं करनी है यहाँ पे. It will resolve. It will resolve. Not an indication for hysterectomy. Just wait and watch. Give some tocolytic agents, okay, and it will resolve. So this part is very important. How to differentiate between placenta previa and abruptio placenta. So in case of placenta previa, there is a sudden bleeding. Sudden onset of bleeding. Sudden onset of bleeding. Onset of bleeding which is bright in color. Bright in color. Painless bleeding and causeless bleeding. Tone of the uterus, relaxed uterus, soft, non-tender uterus in case of placenta previa. Sterlworthy sign is seen in to assess the presentation of placenta in case of posterior placenta. If the placenta is implanted posteriorly, Sterlworthy sign. So again, features in case of placenta previa, sudden onset of painless, causeless and recurrent bleeding. Uterus will be relaxed, non-tender and soft. But in case of abruption, bleeding associated with pain. Associated with pain. Cause could be trauma and pregnancy-induced hypertension. Pregnancy-induced hypertension. Uterus will be tender, hard and tensed. Tender, hard and tensed. So, okay, tell me, what are the causes of abruptio placenta? Yes, causes of abruptio placenta. Just remember the mnemonic abrupt. Mnemonic abrupt. A stands for advanced maternal age. B means blood pressure disorders like preeclampsia, pregnancy-induced hypertension. R stands for rupture of membranes, premature rupture of membranes. U stands for uterine fibroid, uterine trauma. P stands for twin pregnancy polyhydramnios. T stands for thalassemia, folic acid deficiency, smoking. So these are the causes of abruptio placenta. Just remember this mnemonic abrupt. Okay. Now, yes, pool of blood. इसमें ऐसे होता है कि फीमेल सुबह उठती है तो वो देखते हैं कि वो एक pool of blood में है, but basically ऐसा नहीं होता है. Blood होगा, not a pool of blood. Next one. Features of placenta previa and abruption. Continue. Okay. Fundal height in case of placenta previa will be equal to period of gestation. in case of abruptio, concealed type, height of the fundus will be more than period of gestation. Fetal heart rate, placenta previa, you can easily heard. But in case of abruption, not audible. PV examination in case of placenta previa, PV examination is contraindicated. As I told you, placenta is a highly vascular. At term, volume of placenta is around 500 ml. So PV is contraindicated in case of placenta previa. But yes, in case of abruptio, first rule out placenta previa, then we can do PV. We can do PV. Even we have to do PV examination in case of abruption. Because in abruption, patient will come with hard tender uterus, sometimes almost with uterine contractions. Because what happened in abruptio placenta, after separation of placenta, there is a release of thromboplastin. This thromboplastin is responsible for initiation of labor, uterine contraction and DIC. The most common complication in case of concealed abruptio placenta is DIC. DIC, disseminated intravascular coagulopathy. Next one, investigation. For screening of placenta previa, transabdominal sonography. For screening, if patient come with bleeding, first step ultrasound. But investigation of choice, TVS, transvaginal sonography. But in case of abruption, ultrasound is not important because it is diagnosed clinically. Clinically diagnosed. So this is not important to do ultrasound in case of abruption. So most common type of placental abruption, concealed type, because there is a risk of DIC, disseminated intravascular coagulopathy. Investigation of choice in case of antepartum hemorrhage, ultrasound. First of all, do ultrasound, check the position of the placenta. If the placenta is on the upper side, it means this is a case of abruptio. If placenta is present in the lower segment of uterus, it means this is a case of placenta previa. Okay, now management. In placenta previa, we can do conservative management and active management. If the vitals of the patient are stable, fetal heart rate is normal, no fetal distress, bleeding, no active bleeding, ultrasound is normal, no anomaly, gestational age if less than 37 weeks of gestation, then management is conservatively. According to McAfee-Johnson's protocol, we have to take the pregnancy till 37 weeks of gestation for lung maturity. Admit the patient, okay, give tocolytic, give steroids and wait and watch. Then after that, cesarean section. So what is the active management? If the vitals are unstable, fetal heart rate means if there is a fetal distress, bleeding, active bleeding is present. Ultrasound is abnormal or showing congenital anomaly Period of gestation more than equal to 37 weeks, then immediate cesarean section. Immediate cesarean section. So this is the active management of placenta previa. Placenta previa. Now, management of abruption. If the patient is in labor, there is no major separation, fetal heart sound are good, then we have to just give injection oxytocin, then artificial rupture of membrane, augmentation of labor. Augmentation of labor. Just increase the uterine contractions. Augmentation means just accelerate the uterine contractions because patient is in labor. Active management. So this was the conservative management. Active, if patient is not in labor, cervix is not favorable, major separation with fetal distress, next step is immediate cesarean section. Immediate cesarean section. So this is the management of abruptio placenta. So next topic is twin pregnancy. Twin pregnancy. So twin pregnancy, incidence of twin pregnancy are high. Why? Because of IVF procedures. IVF procedures. Advanced maternal age, poor egg quality, then IVF procedures. So what is the most common type of twins? Most common type of twins, there are two types of twin pregnancy, dizygotic and monozygotic. Most common type of twins, dizygotic, then monozygotic twins. Most common type of monochorionic twins, monochorionic diamniotic. So type of monochorionic twins depends on the type of splitting. Means after the formation of zygote, it will divide it into two at different time period. So I have tried to make these diagrams so that you people can understand easily. देखते हैं. So if splitting occurs before 3 days, this is called as dichorionic diamniotic twins. Dichorionic diamniotic twins. If the splitting occurs before 3 days, dichorionic diamniotic twins. If splitting occurs between 4 to 8 days, this is called as monochorionic diamniotic twins. If splitting occurs between 8 to 12 days, this is called as monochorionic monoamniotic twins. After 12 days, monochorionic monoamniotic conjoined twins. Okay, clear? So these are the types of monochorionic twins. Depend upon the splitting of this embryo at different time periods. So what are the complications specific to monochorionic twins? Twin to twin transfusion syndrome, TRAP, twin reverse arterial perfusion, TRAP, TAPS, twin anemic polycythemic syndrome. So these are the complications which are associated with monochorionic twins. So what is the complication specific to monochorionic monoamniotic twin? Specific complication. दोनों बेबीज एक ही सैक में हैं, एक ही एमनियोटिक सैक में. कॉर्ड एंटेंगलमेंट, कॉर्ड एंटेंगलमेंट, कॉर्ड आपस में फंस जाएंगी. In case of monochorionic, monoamniotic twins, most common complication, cord entanglement. So always delivered by 32 to 34 weeks by elective cesarean section because of complications delivered by elective cesarean, planned cesarean section at around 30 to 34 weeks of pregnancy with steroid coverage. In case of monochorionic, monoamniotic twins. Monozygotics are identical twins. Dizygotic are non-identical twins. So in case of dizygotic, sex it could be both female or one female, one male, but in identical twins, sex will be the same. Blood group, same. Phenotype, same. Only fingerprints will be different in case of identical twins. Okay. So investigation of choice to know the chorionicity. Ultrasound at around 10 to 14 weeks of pregnancy. 10 to 14 weeks of pregnancy. Twin, so look at these images. These are ultrasound images of, this one is the dichorionic diamniotic twins. This one is the monochorionic diamniotic twins. So ultrasound at around 10 to 14 weeks of pregnancy. In dichorionic diamniotic twins, you will see the lambda sign. This is the lambda sign. Lambda sign between two gestational sac 1 and sac 2. So this is called as lambda sign. Lambda sign in dichorionic diamniotic twins. Or T sign is seen in monochorionic diamniotic amniotic twins. T sign. So this is the T sign which is seen in monochorionic diamniotic twins. If we talk about the membranes, layers of membranes between dichorionic diamniotic, 4 layers. 4 layers are present. Chorion, amnion, amnion, amnion and chorion. In case of monozygotic, 2 layers are present. Only amnion and amnion. Thickness of membranes more than equal to 2 mm in case of dichorionic diamniotic. In case of monochorionic diamniotic, less than 2 mm. Thickness of the layers, thickness of the membranes. Thickness of the membranes. Okay, clear? Now, mode of delivery depends upon the presentation of first twin. Always first twin. The most common presentation is vertex. Cephalic presentation is the most common presentation. If the first twin is vertex, then we can do vaginal delivery. Always vaginal delivery. If first twin is breech and transverse, then only C-section. Only C-section. See, if the first twin goes, this is the uterus, first twin. So this one is the first twin in a cephalic presentation. This is the first twin, first. And second twin in a breech presentation. In second diagram, first, this is the first twin in a vertex presentation, second twin in a transverse line. Then what is the treatment? As I told you, Mode of deliveries depend upon the presentation of first twin. So first twin is vertex, vaginal delivery. First in vertex, second is breech, again vaginal delivery. पहले बेबी को निकाल लो, सेकंड बेबी assisted breech, vaginal delivery. In case of transverse lie, first baby vertex, second baby transverse. Then we can do vaginal delivery. First of all, do vaginal delivery of the first twin, then internal podalic version in case of transverse lie. Transverse lie. So only indication for internal podalic version is seen in second twin in transverse lie. Very, very important. Look at this image. After delivery of the first twin, internal podalic version. बेबी के पैरों को पकड़ो, ब्रीच में लेके आओ और निकाल लो. Internal podalic version. So this is all about management in case of twin pregnancy. अगर first twin breech है, transverse है, then always cesarean section. Now, important topic, important one, hypertension in pregnancy. Hypertension means if the blood pressure is more than and equal to 140/90 on 2 occasions, 4 hours apart, is called as hypertension in pregnancy. Now we have two situations. First one, pregnant female is known case of hypertension. Means there is a history of hypertension before pregnancy. This is called as chronic hypertension in pregnancy. Means this female is already known case of hypertension. So what is the meaning of pregnancy induced hypertension? In this female there is no history of hypertension before pregnancy, but at around 20 weeks there is a rise in BP. 20 weeks rise in blood pressure is called as pregnancy induced hypertension after 20 weeks. So clear? First situation, female is already hypertensive before pregnancy is called as chronic hypertension. Pregnancy induced hypertension means she was not hypertensive before pregnancy. Now she is hypertensive at around 20 weeks of pregnancy. Again, pregnancy induced hypertension is divided into gestational hypertension and preeclampsia. In both the conditions, BP will raise at around 20 weeks of pregnancy but gets normal after 12 weeks after delivery. So this is called as pregnancy induced hypertension. BP raised after 20 weeks of pregnancy, then gets normal after 12 weeks after delivery. So what is the difference between gestational hypertension and preeclampsia? Mild preeclampsia means BP more than and equal to 140/90 but less than 160/110. This is called as mild preeclampsia. Severe preeclampsia means BP more than equal to 160/110. Mild and severe. So in case of gestational hypertension, protein urea and end organ damage signs will be absent. But in case of preeclampsia, protein urea and signs of end organ damage will be present. So this is the difference between gestational hypertension and preeclampsia. Clear? Now, protein urea means 24-hour urinary proteins if more than 300 milligrams. protein creatinine ratio more than 0.3, dipstick method 1 plus proteins are present. So this is called as proteinuria. So what is the meaning of signs of end organ damage? If the creatinine is more than 1.1, platelet count less than 1 lakh, liver enzyme raised 2 times than the normal values, pulmonary edema present, cerebral and visual symptoms are present. So this is called as signs of end organ damage. Okay, now, so hypertension is in pregnancy is a full of terms. Chronic hypertension, gestational hypertension, pregnancy-induced hypertension, eclampsia, chronic hypertension with superimposed preeclampsia. Number of definitions are there. So eclampsia means severe preeclampsia with generalized tonic and clonic seizures. This is called as eclampsia. Means in case of severe hyperclampsia, अब patient को क्या होगा? Seizures आने शुरू हो जाएंगे. This is called as eclampsia. So this one is important. Signs of impending eclampsia. So what are the signs of impending eclampsia? Headache. Patient will complain of headache. Dizziness, headache due to cerebral edema. Second one, epigastric pain, nausea due to stretching of liver capsule. Third one, first one headache, dizziness, epigastric pain, nausea. Third one, visual disturbances. Like blindness which is reversible, blurring of vision, scotoma. Sometimes black dots आने लग जाते हैं eyes के आगे. ठीक है? So these are the signs of impending eclampsia. 3 main signs. Okay, impending eclampsia means कि अब इस पेशेंट को सीजर्स आ सकते हैं. दिस इज कॉल्ड एज impending eclampsia. Okay, now, so oligouria will be there, but signs of impending eclampsia are these 3 points. Okay, oligouria will be there. So most common cause of sudden death in women with eclampsia. So these are the one-liner questions. Most common cause of sudden death in a woman with eclampsia. Yes, anyone? Intracranial hemorrhage. Most common pathology of pregnancy-induced hypertension. Vasospasm of spiral artery because of incomplete invasion of trophoblast. Incomplete invasion of trophoblast. So this is the pathology of pregnancy-induced hypertension. तो ब्लास्टोसिस्ट, अगेन ब्लास्टोसिस्ट पे आ जाते हैं. इम्प्लांटेशन उसी ने किया था तो उसी पे आते हैं ब्लास्टोसिस्ट पे. तो ब्लास्टोसिस्ट, outer layer is called as trophoblast. So this is the blastocyst. Outer layer is the trophoblast. Inner layer is the inner cell mass. Then trophoblast on 8th day after fertilization will divide it into cytotrophoblast and syncytotrophoblast. So cytotrophoblast, function of the cytotrophoblast to produce hormones, hormone factory of the placenta. So cytotrophoblast further divided into villous and non-villous. So in villous trophoblast, they are further divided into interstitial and endovascular trophoblast. So these endovascular trophoblasts invade the spiral artery. They will invade the spiral artery and replace the smooth muscle layer of the spiral artery. It will cause the dilatation of the spiral artery ताकि अच्छे से blood जाए intervillous space में. So what happened in pregnancy induced hypertension? There will be a narrowing of spiral artery because of incomplete invasion of endovascular trophoblast. So this is the pathology of pregnancy induced hypertension. Clear? Now, this is a PYQ, complication of severe preeclampsia. HELP syndrome. HELP syndrome. H stands for hemolysis, EL means elevated liver enzymes, LP means low platelet count. So this is a complication of severe preeclampsia. Okay, now what are the anti-hypertensive drugs which can used in hypertension in pregnancy? Anti-hypertensive drugs. Anti-hypertensive drugs, first one is the labetalol. Labetalol is the first drug, best but contraindicated in asthma. Second drug is methyl dopa. Methyl dopa. Third one is nefidapine. So these are the drugs which we can use, antihypertensive drugs in case of pregnancy induced hypertension in a chronic hypertension. Okay, but in case of hypertensive crisis, uncontrolled BP है patient का, hypertensive crisis, then injectable labetalol with the total dose of 220 milligrams. Injection labetalol 220 milligrams in a divided dose. First we have to give 20 milligrams, wait for 15 minutes, then 40 milligrams, wait for 15 minutes, then 80 and 80. In a divided dose is 220 milligrams. Or we can give injection hydralazine with a dose of 30 milligrams in case of hypertensive crisis, uncontrolled BP. Okay, now what is the definitive management in case of mild preeclampsia? So definitive treatment in pregnancy is termination of pregnancy. Termination of pregnancy is a definitive management. Termination of pregnancy is the definitive management of hypertension in pregnancy. In case of mild preeclampsia, termination after 37 weeks of gestation. In case of severe, after 34 weeks of gestation. 34 weeks of gestation. So immediate termination of pregnancy in case of HELP syndrome, in case of eclampsia, or in case of impending eclampsia. Termination of pregnancy is the definitive management of preeclampsia, eclampsia, impending eclampsia and HELP syndrome. Because हमें पहले किसको बचाना है? मदर को. Otherwise मदर की डेथ हो जाए. Okay. Now this is a PYQ. anti-hypertensive drugs contraindicated in pregnancy. First of all, ACE inhibitors. ACE inhibitors, angiotensin receptor blockers like losartan, diazoxide and diuretics. It will cause IUGR because of decreased perfusion of the placenta. We can give diuretic in case of pulmonary edema or in case of congestive heart failure. So these drugs are contraindicated in pregnancy. Okay, now solve this question. 35-year-old female, 33 weeks pregnant, in her first pregnancy. She is primi gravida. She has a 1-day history of headache, blurred vision, uncontrolled BP, blood pressure, urine analysis, 2+ proteins. 2 weeks prior, BP was 140/100. Initial drug to start. So first of all, what is the diagnosis? So this is a case of preeclampsia, severe preeclampsia, eclampsia and impending eclampsia. What is the diagnosis here? So this is a case of impending eclampsia, headache, blurring vision. So this is a case of impending eclampsia. So initial drug to start is intravenous magnesium sulfate, drug of choice. So we have to give magnesium sulfate by Pritchard regime. We have to give 14 grams of magnesium sulfate, 4 gram intravenous slow and 10 grams divided into 5 + 5 intramuscular. Maintenance dose 5 milligrams intramuscular on alternate side 4 hourly till 24 hours after delivery. So this is called as Pritchard regime. Magnesium sulfate is a drug of choice in case of impending eclampsia and eclampsia. Okay, now before maintenance dose, monitor magnesium. This is very important to monitor. We have to monitor first one, knee jerks to check the magnesium toxicity. Okay, then respiratory rate, it should be more than and equal to 14 breaths per minute. And urine output, very, very important because magnesium is excreted in urine. Urine output should be more than 100 ml in 4 hours. Before maintenance dose, please remember this point. Deep tendon reflex should be present, knee jerks, respiratory rate should be more than 14 breaths per minute, and urine output should be more than 100 ml in 4 hours. Very, very important. Signs of magnesium toxicity. First of all, first sign is loss of knee jerk at around 10 milliequivalent dose. Respiratory depression at around 12, respiratory arrest at around 15 and cardiac arrest more than 24. Value of magnesium sulfate. Normal values are around 4 to 7 milliequivalent per liter. Magnesium sulfate. So this is all about hypertension in pregnancy. Any doubt you can ask me. hypertension? Yes, antidote is calcium gluconate. Calcium gluconate injection. Next topic is diabetes in pregnancy. So which hormone is responsible? So which hormone is responsible for insulin resistance? Estrogen, progesterone, cortisol, prolactin, but mainly which hormone is responsible for insulin resistance? That is injection HPL, human placental lactogen, maximum at around 24 weeks of pregnancy. 24 weeks of pregnancy maximum. For preeclampsia, best is to do ultrasound Doppler and ultrasound. Some blood investigations, all like we have to check for CBC, we have to check for platelet count. So there are two types of diabetes in pregnancy. First one, overt diabetic. Second one, gestational diabetes. Overt diabetes means this is a known case of diabetes before pregnancy. Gestational diabetes means there is no history of diabetes before pregnancy, but at around 24 weeks of gestation, now she is diagnosed as a GDM, gestational diabetes mellitus. So clear? Now, screening is very, very important for GDM. Time of screening on first antenatal visit. Why? Because first trimester is a period of organogenesis, formation of organs in first trimester. High sugar level leads to formation of free radicals. But these free radicals are phytotoxic. They will cross the placenta and it will cause congenital malformation. So this is very, very important to do screening in case of diabetes in pregnancy. So we have two tests by Government of India, by DIPSI guidelines on first antenatal visit. Irrespective of previous meal, we have to give 75 grams of sugars, oral sugar to the patient. And then we have to check the sugar levels after 2 hours. If the levels are more than 140, it means this is a case of GDM. Okay. If the levels are more than 200, then this is a case of overt diabetes. Okay. So this is by DIPSI guidelines, Diabetes in Pregnancy Study Group of India. By WHO, screening can be done any time during pregnancy, but fasting. Again, give 75 grams of oral sugars. If the FBS is more than 92, 1 hour sugar is more than 180, 2 hour sugar is more than 150, it means this is a case of GDM. If the fasting is more than 126 and 2 hours is more than 200, it means this is a case of overt diabetes. Clear? Screening. 2 tests are important. Okay. Now, management. GDM management is diet modification and exercise. After 2 weeks, check the blood sugar levels. If 2-hour sugar is less than 120, then again diet, postprandial sugar, diet modification plus exercise. But if 2 hours postprandial sugar is more than 120, then we have to start insulin. In case of overt diabetes, start insulin. There is no role of diet modification and there is no role of exercise. Start insulin, dose 0.721 international unit per kg weight. In overt diabetes, because we have to start insulin. Otherwise, uncontrolled sugar will lead to congenital malformation. So, time of delivery, well, in case of GDM, well controlled on diet, we can deliver after 39 weeks. Controlled on drugs, we can deliver between 38 to 39 weeks. 38 to 39 weeks. In case of overt diabetes, controlled on insulin, more than 37 weeks. Uncontrolled, in case of uncontrolled, more than 34 weeks. This is the time of delivery in case of GDM and overt diabetes. Mode of delivery, preferably vaginal delivery. If the weight of the fetus is more than 4.5 kg, macrosomia, then cesarean section. So, oral drugs are contraindicated, but we can give metformin and glyburide in second and third trimester. Okay. So, metabolic goals of insulin treatment. Fasting should be less than 97. Postprandial should be less than 120. HbA1c should be less than 6 is the metabolic goal of insulin treatment. So, this is all about diabetes in pregnancy. Now, solve this question. 28-year-old female suffering from GDM delivered at term. Neonate was having macrosomia, got admitted to neonatal ICU. Then the answer is C. Neonatal hypoglycemia is the most common complication associated with GDM. Most common complication, because there is a hyperplasia of beta cells of pancreas, because maternal hyperglycemia, now fetus is depend upon the mother now for glucose. So, maternal hyperglycemia, it will cause fetal hyperglycemia, and hyperplasia of beta cell or pancreas means there is an increased secretions of insulin from fetal side. After delivery, the source of sugars has gone. Now, that's why it will cause hypoglycemia in the neonates. So, congenital anomalies are present in overt diabetes. GDM is diagnosed after 24 weeks. Till then, organogenesis period निकल जाएगा. Okay. So, So what is the most common cardiac anomaly in overt diabetes? Both most common cardiac anomaly in overt diabetic patient. VSD, yes, ventricular septal defect. And what is the most specific cardiac anomaly? Most specific cardiac anomaly. TGA, transposition of great vessels. And most specific anomaly is caudal regression syndrome. Sacral agenesis. Sacral agenesis. Okay, now next topic is preterm labor. Preterm labor. Preterm labor means if labor starts before 37 weeks of pregnancy. This is called as preterm labor. So what are the causes of preterm labor? Infections. Most common causes, infections. There could be uterine anomalies, uterine overdistension, uterus anomalies, placental anomalies, maternofetal distress, antepartum hemorrhage, polyhydramnios. Okay, now how to diagnose preterm labor? How to diagnose preterm labor? First of all, uterine contractions. If there are more than 4 contractions in 20 minutes, more than equal to 8 contractions in 60 minutes, length of the cervix less than 2 centimeter, and the dilatation of the cervix is more than 3 centimeter. This is a diagnosis of preterm labor. Presence of fibronectin protein in cervicovaginal discharge more than 50 nanogram per deciliter. Normally, fibronectin protein is present before 22 and after 37 weeks of gestation. If detected in between period of 22 and 37 weeks, if detected in between, this is called as, then we can say this is a case of preterm labor. This is a case of preterm labor. Okay, now, so what are the problems with preterm labor? Problems with preterm labor. First of all, lung will not mature. It will cause respiratory distress syndrome. Respiratory distress syndrome. Brain will not mature. It will cause cerebral palsy. Cerebral palsy. Chances of infections. So these are the problems which are associated with preterm labor. Preterm labor. Intraventricular hemorrhage. Intraventricular hemorrhage. Necrotizing enterocolitis. So these are the complications in case of preterm labor. So investigation of choice, ultrasound TVS. Ultrasound TVS to check the dilatation of cervix. Funneling of internal oats. Shape of the cervix, T to Y, then V, then U shape. T shape means closed cervix. U shape means open cervix. Investigation of choice, ultrasound TVS. Now, what is the management in case of preterm labor? Management in case of preterm labor. First of all, for lung maturity, corticosteroids. Dose of dexamethasone 6 milligrams 12 hourly for 6 milligrams 12 hourly, 4 doses. So we can give dexamethasone and betamethasone. Betamethasone 12 milligrams into 24 hourly, 2 doses. 2 doses. So this is the management with corticosteroids for lung maturity. Next one, tocolytic agents. Tocolytic agents, they decrease the uterine contractions in latent phase or active phase. In which phase? Tocolytic agents to decrease the uterine contractions in the latent phase of labor. Latent phase of labor. And the dilatation is less than 3 centimeters. Period of gestation less than 34 weeks. Cervical dilatation less than 3 centimeter. Most commonly used drug for tocolytic agent? Yes, most commonly used drug, nifedipine. Most commonly used drug. Start dose 30 milligrams, then maintenance dose 10 to 20 milligrams. Most commonly used drug is nifedipine. Drug of choice in heart patients, 𝗘𝗱𝗶𝗁. This is the drug of choice in heart disease patient. So what are the other tocolytic drugs? What are the other tocolytic drugs? Beta agonist. So these are retodrine, salbutamol, terbutaline, isosuprin. So these are the beta agonistic drugs which are used as a tocolytic agents, but they have maximum side effects, maternal side effects like tremors, pulmonary edema, hyperglycemia. Okay, so most commonly used drug is nifedipine. We can give prostaglandin inhibitor. Drug name is indomethacin. But before 32 weeks of gestation only. Before 32 weeks. If we give this drug after 32 weeks of pregnancy, then it can lead to premature closure of ductus arteriosus. So this is the indomethacin. We can give magnesium sulfate. We can give, but this is not a tocolytic agent. We can give only as a neuroprotector. In a extreme preterm labor before 32 weeks only. Long use of magnesium sulfate can lead to hypocalcemia in the fetus, thinning of the bones. Okay, now solve this question. Primi gravida came in spontaneous preterm labor at around 32 weeks of pregnancy. There is no medical history. There is no history of fever, high blood pressure, no leakage, no bleeding. She is 4 centimeter dilated, 80% effaced. A bag of membrane is present. What is the appropriate management in this case? So, tocolytic agent we can give only if the cervical dilatation is less than 3 centimeter. Now, she is 4 centimeter dilated and 80% effaced. 80% effaced. Means she is in active stage of labor. Tocolytics are recommended only in the latent phase of labor. What is the answer? So the answer is D. She is 32 weeks pregnant. So give steroids for lung maturity and allow the labor to progress. Now she is in active phase, 4 centimeter dilated, 80% effaced. So better to give steroids and labor to progress. Okay. Now, second one, you are examining a term patient in a labor room. Which of the following findings are most likely to indicate rupture of membranes? So, premature rupture of membrane means if membrane ruptured beyond 37 weeks of gestation, but before the spontaneous onset of labor. This is called as premature rupture of membrane. Just we have to check whether this is a amniotic fluid or vaginal discharge. We have to check the alkaline nature of the amniotic fluid. Amniotic fluid is alkaline in nature with the pH of 7.3 to 7.4. Vaginal discharge is acidic, 3.5 to 4. So, pH 4 point means no, this is not a ruptured case. Okay. Wet clothes, there could be a urine output, urine pass हो सकता है female का. Yellow green color on nitrogen test. No. So answer is C. C. Acidic होगा, sorry, अगर yellow है it means this is a acidic. Blue होगा, this means this is a alkaline. So answer will be furning on the specimen from vaginal pool. Amniotic fluid में क्या होगा? Furning because of sodium chloride. Furning on a specimen from vaginal pool. This is the right answer. Now, maternal pelvis, most common, gynecoid pelvis, classic female pelvis. Transverse diameter is more than anterior posterior diameter. Okay. So, maternal pelvis is important. This was the PYQ. Anthropoid pelvis. Anterior posterior diameter is more than transverse diameter. So, in this case, there will be a persistent occipito-posterior position. Persistent and phase to pubic delivery. So, phase to pubic delivery is seen in anthropoid pelvis. So, anterior posterior diameters are more than transverse diameter. And android pelvis, transverse diameter is more than anterior posterior diameter, this diameter, and there is a prominent ischial spine. And the internal rotation of fetal head takes place at this point. Internal ischial spine. Most common cause of occipito-posterior position during labor and deep transverse arrest. Android pelvis. Next one, platyploid pelvis. Transverse diameter is more than anterior posterior diameter. So, phase presentation is seen in platyploid pelvis. Clear? So, these are the types of pelvis. Now, so this is the PYQ, anterior posterior diameters of pelvis. Okay. So, this is the pubic symphysis. This is the sacrum promontory. So, from the upper border of the pubic symphysis to the sacral promontory is called as true conjugate, 11 centimeter. Middle of the pubic symphysis to sacral promontory, obstrate conjugate. Lower border the pubic symphysis to sacral promontory. This area, this is called as diagonal conjugate. So, cavity diameter is around from the middle of the pubic symphysis to S2 and S3. This is a mid pelvis diameter around, cavity diameter around 12 centimeter. So, these are the outlet diameters, 11.5 to 13 centimeters. 13 centimeters. The true conjugate is around 11 centimeter. Obstetric conjugate 10.5 centimeter is the diameter. Diagonal conjugate 12 centimeters. Cavity pubic symphysis to S2 and S3 is around 12 centimeters. Outlet lower border of the pubic symphysis to coccyx is around 13 centimeters. So these are the anterior posterior diameter of the pelvis. Clinically, we can measure only diagonal conjugate. Diagonal conjugate. Normally, fingers can't touch the pubic, the sacral promontory. If they are touching, it means diagonal conjugate is less than 12 centimeter. Diagonal conjugate is less than 12 centimeters. So, contracted pelvis, if the contracted inlet, it means obstetric conjugate is less than 10 centimeters. Is less than 10 centimeters. Contracted mid pelvis means if the interstitial diameter, normal interstitial diameter is around 10 centimeter. If it is less than and equal to 8 centimeters. Contracted outlet means if the bituberous diameter is less than and equal to 8 centimeter. So normally this one is a 10 centimeter, this one is a 10.5 centimeter, and bituberous diameter is around 11 centimeter. So if there is if major diameters are shortened by 0.5 centimeters or more, these are the major diameters. If they are shortened by 0.5 centimeters or more, so this is called as contracted pelvis. Contracted pelvis. So there is no role of trial of labor. Always do cesarean section. Always do cesarean section. Okay, now, so these are the diameters of fetal skull. Diameters of fetal skull. So first of all, antero-posterior diameter. Just remember the mnemonic in SOS, send SMS. So SOS means this area, occiput. Let's talk about the diameter from occiput. So occiput or suboccipito-bregmatic. So this diameter is the suboccipito-bregmatic, 9.5 centimeters. Occiput to frontal, this is a 11.5 centimeter. Then occiput to frontal, so this is a occiput to frontal is around 10 centimeters. तो ये वो डायमीटर्स हैं जो ऑसिपुट से हम मेजर करते हैं. सब ऑसिपिटो ब्रैग्मेटिक, ओके, ऑसिपिटो फ्रंटल एंड ऑसिपिटो सब ऑसिपिटो फ्रंटल, सब ऑसिपिटो फ्रंटल. नाउ फ्रॉम मेंटो, this is the mentum part of the skull, mentum. From submento-bregmatic, so submento-bregmatic, this one, so this one is a 9.5 centimeters. Mento vertical, from mento vertical, longest diameter of fetal skull, 14 centimeter. Submento vertical, submento vertical, submento vertical is around 11.5 centimeters. So these are the anterior posterior diameters of fetal skull. Just remember the mnemonic in SOS, send SMS. The longest diameter is mento vertical, 14 centimeter, 14 centimeter. Okay. So now, transverse diameters of fetal skull. Just remember the mnemonic, Miss Tina, so pretty. Miss Tina, so pretty. M stands for mastoid, T means temporal, S means super subparietal, and B means parietal. Okay, so bimastoid diameter is around 7.5 centimeters. 7.5 centimeters. This is the smallest diameter of fetal skull. Bitemporal 8 centimeters. Super subparietal 8.5 centimeters, and biparietal diameter is 9.5 centimeters. This is the important diameter, biparietal diameter, because the engagement of fetal head at the time of labor occurs by biparietal diameter, that is 9.5 centimeter. That is 9.5 centimeter. Okay, now labor, important part, labor. So what is the meaning of adequate uterine contractions? Adequate uterine contractions. It means 3 contractions in 10 minutes. 3 contractions in 10 minutes, which is called as frequency. Frequency. Each contraction lasts for 45 seconds. 45 seconds. This is called as duration. This is called as duration. Causing intrauterine pressure. Causing intrauterine pressure up to 65 to 75 mm of Hg. This is called as intensity. This is called as intensity. So, adequate uterine contractions, it means adequate frequency, duration and intensity. Now, so there are 4 stages of labor. First stage starts with true labor pains and ends with dilatation, full dilatation of cervix up to 10 centimeter. Okay. Second stage starts with the full dilatation of cervix and ends by the delivery of the fetus. This is a second stage. Third stage of labor starts with the delivery of the baby and ends with the delivery of the placenta. So this is a third stage. In fourth stage of labor, this is just a observation. Observation for maternal condition and uterine tone. So there are 4 stages of labor. So first stage of labor is the longest stage of labor, divided into latent phase and active phase. Latent phase, according to American guidelines, started up, latent phase is up till 6 centimeter. According to WHO, 5 centimeter. According to partogram, 4 centimeter. सभी का अलग-अलग है. Okay. Active phase starts after dilatation of 6 centimeters according to American guidelines. After 5 centimeters, WHO. After 4 centimeters, partogram. Okay, just remember the values. Okay, now prolonged. Now I will be discussing abnormal labor. Abnormal labor. So prolonged labor, lactant phase means if the primary gravida, if it is more than 20 hours, in multigravida, if it is more than 14 hours. This is called as prolonged latent phase. Prolonged latent phase. So what are the causes? Causes of prolonged latent phase. Occipito, posterior position of the fetal head. Poor contractions, poor uterine contractions and unfavorable cervix. Unfavorable cervix. So these are the causes of prolonged latent phase. Management, just Advise the patient to take rest and sedate the patient. If again uterine contractions are poor, then we can give injection oxytocin for the augmentation of labor. Injection oxytocin. Okay. Now, active phase of labor. In an active phase of labor, there is a rate of cervical dilatation will be more. Cervical dilatation rate is more during active stage of labor. Okay, so according to WHO, minimum cervical dilatation in active stage of labor is around 1 centimeter per hour. 1 centimeter per hour. So what is the meaning of abnormal active phase? So abnormal active phase, there could be a protracted active phase and active phase arrest. Please try to understand. First one, it means slow progress of labor. Second one, active phase arrest. No change in the cervical dilatation. So in a protracted active phase, what are the causes? There could be a hypotonic contractions, means inadequate contractions. Slow progress of labor, means dilatation is less than 1 centimeter per hour. Per hour, slow dilatation of cervix. Causes, first one, hypotonic contraction. Second one, adequate contractions, but there is a no dilatation of cervix. And what is the cause? So in case of hypotonic, we can augmentate this labor. Just increase the uterine contractions by injection oxytocin or artificial rupture of membrane. Artificial rupture of membrane. In case of adequate contractions, we have to do per-vaginal examination. If there is a molding, overlapping of the fetal skull suture, it means CPD is present, cephalopelvic disproportion. Then the treatment is caesarean section. Caesarean section. If there is a occipito-posterior position, then we can wait and watch. Wait and watch. So this is the abnormal protracted active phase. Now, this was a PYQ. Active phase arrest means there is a no change in cervical dilatation. Means at around 4 p.m. dilatation was 6 centimeter. At around 7 p.m. again 6 centimeter. Means there is a no change in cervical dilatation. With 4 hours with adequate contractions, 6 hours with inadequate contractions. Then management will be caesarean section. Caesarean section. So this is the abnormal first stage of labor. Now, prolonged second stage. It means no descent of head with adequate uterine contraction. So in second stage of labor, main event is the delivery of the baby. Maximum fetal descent occurs in the second stage of labor. If there is a prolonged second stage, it means no descent of fetal head with adequate uterine contractions. Then we have to check, we have to do per-vaginal examination to check the fetal status. Fetal head status. So these are the ischial spine. It means the head is at around 0 station. Internal rotation of fetal head takes place at around between ischial spine. Between ischial spine. It means this is station 0. -1 above the ischial spine, -2, -3. Below ischial spine, +1, +2. We can check by per-vaginal examination, the head station of the fetus. If it is above 2 centimeter, above 2 centimeter, this side, then treatment is above 2 centimeter, treatment is cesarean section. But below 2 centimeter, below 2 centimeter, below 2 centimeter, then management is instrumental delivery. We can do instrumental delivery by forceps and by vacuum. For forceps, we can apply on a full dilatation of cervix. Vacuum we can apply when the cervical dilatation is more than equal to 6 centimeter. Cervical dilatation. Dr. Narisha, see, uterine contractions are adequate, then there is no need of oxytocin. Contractions are adequate, but there is no descent of head. So best is to do instrumental delivery if the fetal head station is below 2+ level. Okay, so these are the instruments. Wrigley forceps. This is the outlet short forceps. Second one, Keeland's forceps. So this is the long forceps, or this is called as a rotational forceps. Okay, third one, elastic cup, vacuum. सुना होगा ना, vacuum delivery, elastic cup. So these cups are made of silicone. We can apply easily. So initially pressure generated is around 0.2 kilograms per centimeter square. Then slowly maximum pressure 0.8 kilograms per centimeter square. So what is the position to apply elastic cup? Over the fetal head, on sagittal suture. This is the sagittal suture, center of the skull. 2 to 3 centimeter, the front of posterior fontanelle. So these are elastic cup. Now, prolonged third stage of labor. The normal duration of third stage is around 15 minutes. Maximum is around 30 minutes. Active management only 5 minutes. Prolonged means if the duration is more than and equal to 30 minutes is called as prolonged third stage of labor. What are the causes? Retained placenta. This is the PYQ, components of active management of third stage of labor. So there are 4 points. First one, use of injection 𝗘𝗱𝗏 to mother after delivery of placenta. Injection oxytocin, 10 international unit, IV infusion. Only IV infusion, no IV bolus. Otherwise, it will cause hypotension. cardiac arrhythmia. Okay, delayed cord clamping more than and equal to 1 minute, so that fetal can get extra 80 ml of blood. 80 ml of blood. Deliver placenta by controlled cord traction. Controlled cord traction. By Brand-Andrews, modified Brand-Andrews method. Controlled cord traction. Intermittent assessment of uterine tone in every 15 minutes for 2 hours. For 2 hours. So these are the components of active management of third stage of labor. So look at this image. This is a Ritzen's maneuver for the controlled delivery of fetal head to avoid perineal tear. To avoid perineal tear. So this is a Ritzen's maneuver. So there are 3 cardinal movements of labor. Just remember the mnemonic. Every doctor friend in Egypt eats raw eggs. So E stands for engagement of fetal head. Engagement of fetal head. D stands for descent. F means flexion. Flexion like this. This is the flexion of fetal head. I means internal rotation at the level of ischial spine. E, after internal rotation, there is a extension of the fetal head. After extension, there is a external rotation. And then expulsion of the fetus. Expulsion of the fetus. Just remember this mnemonic. Every doctor friend in Egypt eats raw eggs. There are 3 cardinal movements of labor. Okay. Now, next topic is postpartum hemorrhage. Postpartum hemorrhage means any bleeding from the genital tract of the female after the birth of the baby is called as PPH. PPH. Postpartum hemorrhage. So most common cause of, there are 2 types of PPH, primary and secondary. So what is the most common cause of PPH? Primary PPH. Primary PPH. Primary PPH means if bleeding occurs within 24 hours of delivery. If bleeding occurs within 24 hours of delivery, most common cause is atonic uterus. Atonic uterus. So what is the most common cause of secondary PPH? Secondary PPH means if bleeding occurs after 24 hours of delivery till 12 weeks. That is called as secondary PPH. And the most common cause of secondary PPH is retained placental bits. Retained placental bits. So clear? Primary PPH and secondary PPH. Management is very, very important. Uterotonic drugs. First line drug, oxytocin, 12 international unit, IV infusion. No IV bolus. It will cause cardiac arrest and hypotension. Side effect. So second drug, methyl ergometrin. 0.2 milligrams intramuscular only. No IV infusion. No IV infusion. Or IV bolus. No. Only IM. Because it will cause forceful uterine contraction. Normally uterus ऐसे contract करेगा, but with the use of methyl ergometrin कैसे contract करेगा? Forceful. एकदम से contract कर जाएगा uterus. So that's why only give intramuscular. So contraindicated in. Just remember the mnemonic 𝗘𝗱𝗶. mnemonic topper. E means after the delivery of first twin. O means organic heart disease. P stands for pre-eclampsia. E stands for eclampsia. R stands for Rh negative pregnancy. So methyl ergometrin is contraindicated in topper. Okay. Now third drug, carboprost, prostaglandin F2 alpha. Carboprost. Dose 250 microgram intramuscular. Maximum we can give up to 2 grams of dose. Injection carboprost. Injection carboprost. Yes, carboprost is contraindicated in asthma patient. So we have to give this dose in a divided dose, means every 15 minutes. Maximum 8 doses every 15 minutes. Okay. So fourth drug is misoprost. Fourth drug is misoprost. 800 microgram. 800 microgram misoprost. So these are the mainly 4 uterotonic drugs: injection, oxytocin, methyl ergometrin, carboprost and misoprost. We can give per rectal, orally. Okay. Now, if bleeding persists, then mechanical compression. Mechanical compression. If there is a still bleeding, then uterine compression sutures. Mechanical compression means we can use Bakri balloon, we can use Foley's catheter, balloon tamponade. Okay. Yes, we can, first of all, in case of PPH, first of all, resuscitation, maternal resuscitation is very, very important. Then uterine massage plus injection tranexamic acid. Tranexamic acid. This is the first step. First of all, we have to stabilize the patient, resuscitation, uterine massage, injection Tranexa, then uterotonic drugs. Then next step, if bleeding persists, mechanical compression. Bimanual uterine compression. Then uterine compression suture, surgical intervention. We can give Lynch suture, Heyman suture and Co-square sutures for the compression of the uterus. If still bleeding, then stepwise devascularization procedure. Bilateral uterine artery embolization, bilateral ovarian artery embolization, or embolization of internal iliac artery. But if there is a no response, then failed medical treatment, failed surgical treatment, then next step is subtotal hysterectomy. So this is a treatment of PPH. Very, very important for your exam, treatment of PPH. So this is a one-liner, most common cause of shock after delivery. That is postpartum hemorrhage. Most common shock immediately after delivery is uterine inversion. Turning inside of the uterus outwards. This is a uterus, inside of the uterus, inside the cavity and outside. This is called as uterine inversion. Uterine inversion. First of all, in uterine inversion, there will be a neurogenic shock, then hemorrhagic shock. The cause of the death in case of uterine inversion is hemorrhagic shock. Treatment: as soon as you have diagnosed this is the case of uterine inversion, then reposition of the uterus. Reposit the uterus. Now answer this question. 26-year-old 𝗘𝗱𝗶𝗁 had delivered 2.7 kilograms of infant. Labor was complicated by severe preeclampsia. Bimanual massage of the uterus and intravenous oxytocin don't control her postpartum hemorrhage. What is the next step? Packing is contraindicated. It will cause infection, more infections. No packing of the uterus. Methyl ergometry, no. This is a case of severe preeclampsia, contraindicated in pregnancy, induced hypertension. Yes, D. So, sutures, bail-in suture is the last step, na? So, first, if there is a no control in bleeding, then next step is to injection 𝗘𝗱𝗶𝗁, prostaglandin F2 alpha. Injection 𝗘𝗱𝗶 is the right answer. Is the right answer. Okay. Now, next step is breech presentation. Breech presentation. The most common presentation of the fetus is vertex, cephalic presentation. Breech presentation, most common cause of breech presentation is prematurity. Prematurity is the most common cause of breech presentation. Now answer this question. Most common cause of transverse lie at term. Transverse lie at term. Placenta previa. Most common malpresentation is in placenta previa is transverse lie. Transverse lie. So this was the PYQ. Highest risk of cord prolapse is seen in. So these are one-liners. Highest risk of cord prolapse is seen in transverse lie. Then footling breech. Then footling breech. Then footling breech. So these are the maneuvers in case of breech presentation. In case of extended breech, so this one is for groin traction in case of flexed breech. Flexed breech. In breech presentation, we can do assisted breech vaginal delivery. Okay. So these are the maneuvers. First one, groin traction in case of flexed breech. In case of flexed breech. In case of extended breech. Extended breech. Extended breech. Pinard's maneuver. Pinard's maneuver. So this is a Pinard's maneuver. Just tap on the popliteal fossa. It will flex the knee. Same on the other side. You can deliver the baby. Pinard's maneuver. In extended breech. Maneuver used in breech delivery for extended arm. For extended arm. अगर आर्म्स ऐसे हैं बेबी की, सी लिम्स डिलीवर हो गई है, ट्रंक हो गया है, तो रह क्या गया? आर्म्स एंड हेड. ओके. So in case of extended arms, Lovesett's maneuver. Just rotate the fetal body so that posterior shoulder becomes anterior. Okay. इसी तरह rotation से we can remove the arms of the baby. This is called as Lovesett maneuver. Lovesett maneuver. Just remember the name of the maneuvers. After coming head delivery, Burns-Marshall maneuver in a flexion position of the fetal head. Burns-Marshall method. Second one, 𝗂𝗡𝗂𝗡 maneuver after coming head delivery. Again, traction on the shoulder, flexion of the fetal head and delivery of the head. 𝗂𝗡𝗂𝗡 maneuver for after coming head delivery. Best method is Piper's forceps. Piper's forceps. This is the best and safest method. So this is a Piper forceps for the delivery of fetal head. For the delivery of fetal head. So clear to all of you? Just remember the name of the mnemonics. Yes, Piper's forceps is only used in case of delivery of fetal head in breech presentation. Okay. Now, so what is the meaning of shoulder dystocia? Means difficulty in delivery of the shoulder. If the head to body delivery time is more than 60 seconds, 60 seconds is called as shoulder dystocia. Shoulder dystocia. So you will see turtle sign in shoulder dystocia. Turtle sign. So what are the risk factors? Just remember the mnemonic DOPA. D stands for diabetic mother. O stands for obese mother or fetus. P means post-term pregnancy. A stands for anencephaly. So these are the risk factors for shoulder dystocia. Management. So this is a PYQ. Management is, just remember the mnemonic helper. First of all, call for help. Call for help. Then we have to consider episiotomy to increase the space. Episiotomy. Then leg maneuvers. Most commonly used first maneuver in case of shoulder dystocia, Mack-Roberts maneuver. Mack-Roberts maneuver. P means pressure externally, suprapubic. First of all, Mack-Roberts maneuver, then suprapubic pressure, means along with suprapubic pressure. First step Mack-Roberts, then suprapubic pressure. Then enter rotational maneuvers. Wood corkscrew maneuver and Robbins maneuver. Rotation of the fetal body up to 180 degree. Wood's corkscrew maneuver and Robbins maneuver. Then R stands for removal of posterior arms. Then roll over onto all four. Gaskin's maneuver and Zanaville. So this is the management of shoulder dystocia. Shoulder dystocia. So this is the image, PYQ, Mack-Roberts maneuver. Hyperflexion of the maternal thigh toward the maternal abdomen and hyperabduction of the hip joint. So this one is the Mack-Roberts maneuver. So this is a Wood's corkscrew maneuver. Rotation of the baby 180 degree. 180 degree. So in case of Mack-Roberts maneuver, after hyperflexion of the maternal thigh, there will be a uplifting of the pelvis. So it will cause increase in anterior posterior diameter of the pelvis and straightening of the sacrum. तो जो head है stuck हो रखा है वो easily बाहर आ जाएगा behind the anterior shoulder which is stuck behind the pubic symphysis. So most common complication, fetal complication in case of shoulder dystocia, brachial plexus injury, 𝗘𝗱𝗶𝗁𝗍 and 𝗘𝗱𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 𝗘𝗱𝗶𝘁 and 𝗘𝗱𝗏-palsy. C5, C6 and C8 T1. Most commonly nerve injured. Most common nerve injured is lateral cutaneous nerve of thigh, nerve of maternal thigh, and most common maternal complication is postpartum hemorrhage. So these are the complications which are associated with shoulder dystocia. So now next topic is induction of labor. Induction of labor, Bishop score, important. Bishop score is used for induction of labor to check the status of cervix, to check the status of cervix. For cervical status, cervical status. There are 5 parameters in Bishop score. 5 parameters in Bishop score. First one, position of the cervix, consistency of the cervix, dilatation, effacement, and station of the fetal head. Station of the fetal head. So these are the 5 parameters of Bishop score. So if the score is more than 9, total scoring is 13. If the score is more than 9, it means induction of labor, it means induction of labor will be successful. If the score is less than 5, it means poor score, poor score. If less than 5, then we have to give cervical ripening agents, cervical ripening agents. So what are the cervical ripening agents? So there are 2 methods. First one, mechanical method. Second one, medical. Mechanical method, we can do Foley's catheter insertion, trans-cervical Foley's catheter insertion, or we can do stripping of membranes, stripping of membranes. So these are the mechanical methods. So what are the medical methods? Use of prostaglandins. So this is important. Misoprost dosed 25 milligrams into 4 hourly. Into 4 hourly. We can use dinoprostone intracervically in the form of Cerviprime gel 0.5 milligram, in the form of Cervidil 10 milligrams. So this is a Cervidil. So there is a slow release of drug, dinoprostone. Just place this Cervidil near the posterior fornix of the vagina for the induction of labor. So there is a slow release of drug. So contraindications of induction of labor. Induction of labor means to induce the labor, we have to start from 0. There is no uterine contraction, we have to start from 0. Induce means, induction means we have to induce. So contraindication, just remember this mnemonic, most high caput, most high caput. Macrosomia, weight of the fetus is more than 4 kg. Hydrocephalus, big head of the baby. Contracted pelvis, CA cervix, active genital herpes, placenta previa and cord prolapse, uterine scar. If there are some uterine scars, then it will cause uterine rupture. Transverse lie, transverse lie. Induction means we have to induce the labor from 0. Initiation of labor is called as induction. So these are the contraindications. So what are the indications of induction of labor? Induction of labor. Indications, induction of labor. So just remember this mnemonic. So I stands for, जब मैं आपको पीपीटी दूंगी आई विल राइट एवरीथिंग, ओके. तो अभी सिर्फ वर्बली, आई स्टैंड्स फॉर इंट्रायूट्राइन ग्रोथ रिटार्डेशन. There is an indication for induction of labor. Okay. D stands for diabetic mother. Diabetic mother. I stands for infections. Infections. Fetal infections. C means chronic hypertension or chronic hypertensive disorders. A stands for abruptio-placenta. Abruptio-placenta. T, twin pregnancy. Again, I, isoimmunization. Isoimmunization. O stands for oligohydramnios. N stands for nulliparous with advanced maternal age. P stands for postpartum pregnancy and premature rupture of membranes. So these are the indications to do induction of labor. Induction of labor. Few topics are left. RH incompatibility. Important topic, RH incompatibility. It means if mother is RH negative and fetus is RH positive. A mother is carrying RH positive fetus. This is called as RH incompatibility. So in RH negative pregnancy, first pregnancy is safe. Because after mixing of feto-maternal blood, if there is a FMH, feto-maternal hemorrhage, even 0.1 ml of fetal blood can sensitize the mother. Okay, so after feto-maternal hemorrhage, if the fetal RH positive blood goes into maternal circulation, then there will be a RH antigen will stimulate maternal immune system. Then anti-D antibodies will form. Anti-D against that RH antigen. Anti-D antibodies will form. Okay, so initially there is a formation of IgM antibodies. So initially there is a formation of IgM. Then after 6 months there is a formation of IgG. So IgM will not cross the placenta, but IgM, they can cross the placenta. But first pregnancy is safe because till then after 6 months delivery हो जाएगी, because feto-maternal hemorrhage maximum can happen in 3rd trimester or during labor. Okay, so initially formation of IgM can't cross the placenta. Then after 6 months there is a formation of IgG. Till then delivery हो जाएगी. IgM doesn't cross placenta. So first pregnancy is safe. In second pregnancy, now maternal immune system is already prepared. If there is a mixing feto-maternal hemorrhage, there is again mixing of feto-maternal hemorrhage. If again baby is RH positive, then antigen antibodies reactions will occur because maternal immune system is already prepared. उनके पहले exposure हुआ था. So first of all, formation of IgM antibodies, then quickly there is a formation of IgG. This is called as amnestic response. Quickly formation of IgG antibodies. These antibodies will cross the placenta. And because of these antibodies, antigen-antibody reaction occur on fetal RBCs, which leads to hemolysis, Clear? First pregnancy is safe, second pregnancy is complicated. So what is the management of Rh negative pregnancy? We have to check anti-D antibodies in maternal serum. कौन सा टेस्ट करेंगे? Indirect womb test. Done on first antenatal visit. Indirect Coombs test. If ICT is negative, it means mother is not yet sensitized. If ICT is positive, it means antibodies are present in a maternal circulation. Means mother is sensitized. So first of all, we have to do indirect Coombs test to check the presence of anti-D antibodies in maternal serum. So we have first case Rh negative mother with ICT is negative, means mother is not yet sensitized. So we have to repeat ICT at around 28 weeks of gestation. Then if again negative, then we have to give injection anti-D 300 microgram, or you can say 1500 intranasal unit to pregnant female. So this is called as antepartum prophylaxis. It means अगर थोड़ा सा भी fetal blood मदर के अंदर गया है तो उसको यूटिलाइज, मतलब उसको न्यूट्रलाइज कर दे. ओके, सो गिव anti-D 300 microgram or 1500 international unit to pregnant female. This is called as antepartum prophylaxis. After delivery, check the blood group of the baby. If blood group is Rh positive, then we have to give anti-D antibody, anti-D injection to mother within 72 hours. Even we can give up till 28 days. Injection anti-D. So first case, primary gravida, Rh negative and ICT is negative. Okay. Now in case 2, pregnant female, Rh negative with ICT is positive, then there is a no role of injection anti-D because mother is sensitized. Already antibodies बन गई हैं. So we have to check the titers, ICT titers. If titers are less than 1:16, it means less antibodies are formed. This is not significant. Okay, so repeat titers every 1 to 2 weeks till 37 weeks. After 37 weeks delivery. Before 12 weeks of pregnancy, अगर हमें anti-D देना है, dose is 50 microgram. After 12 weeks of pregnancy, 300 micrograms. So again, ICT titers, if titers are more than 1:16, it means there is a fetal anemia. Means there is a severe hemolysis. To check the fetal anemia, there is a non-invasive testing, that is middle cerebral artery Doppler. Middle cerebral artery Doppler. ब्रेन स्पेयरिंग इफेक्ट. अब बेबी को पता है कि एसेंशियल ऑर्गन कौन सा है, तो वो क्या करेगा, अपनी ब्लड सप्लाई ब्रेन की ओर बढ़ा देगा. दिस इज कॉल्ड एज ब्रेन स्पेयरिंग इफेक्ट. So in middle cerebral artery, we have to check PSV, peak systolic velocity. If peak systolic velocity is less than 1.5, then there is a no problem. But if more than 1.5, it means there is a severe anemia. Then next step is chordocentesis. Take the sample from the fetal umbilical cord. Check hematocrit. If the hematocrit is less than 30%, then next step is to give intrauterine blood transfusion up till 35 weeks. Up till 35 weeks of pregnancy. So this is a treatment in case of Rh negative female with ICT positive. Now, answer this question. What is the best test for monitoring sensitized Rh negative mother? Means ICT is positive, Rh negative mother, ICT is positive. Which is the best? What is the best test for monitoring a sensitized Rh negative mother? The answer is middle cerebral artery. Doppler of middle cerebral artery. This is the best non-invasive test. Best non-invasive test. We have to check for peak systolic velocity. So this is all about Rh negative pregnancy. इसमें इतना important है treatment of Rh negative. Most common complication, hydrops fetalis. Buddha sign is seen in hydrops fetalis on ultrasound. Here we are doing chordocentesis not for any karyotyping. We are doing as a therapeutic. We are taking sample. Okay. Now, fetal growth, ultrasound, Doppler, umbilical artery Doppler, important one, umbilical artery Doppler. So, single most accurate parameter for fetal growth is abdominal circumference. So, what is the meaning of IUGR? It means estimated fetal weight less than 10th percentile for that gestational age is called as IUGR. This is called as IUGR. So IUGR में Doppler is important. Best investigation for evaluation of growth restricted fetus is umbilical Doppler. Fetal umbilical Doppler. So we have three types of waves, Doppler waves. So first one, in a pregnancy, in a normal pregnancy, there is a forward flow in a umbilical artery. As the pregnancy advances, there is an increased flow, systolic flow and diastolic flow. So in a normal pregnancy, the systolic and diastolic ratio is low because there is a forward flow, systolic flow as well as diastolic flow. So what happened in case of IUGR? First change in umbilical Doppler is decreased diastolic flow. So this is the systolic flow and this is the diastolic flow, systolic flow and diastolic flow. Because of uteroplacental insufficiency, high resistance at the level of placenta. Now fetus is pumping blood, but there is a high resistance at the level of placenta. At this time, SD ratio, which is low during normal pregnancy, will raised. It means there is some problem which is not good for the fetus. This is the first change in umbilical Doppler. Second change. So second change in umbilical Doppler, you can see there is a systolic flow, but no diastolic flow. So this is called as absent and diastolic flow. Absent and diastolic flow. It means there is a problem. There is a problem. Third change, you can see systolic flow in the umbilical artery, but there is a reverse flow in a diastolic. Forward hua, then reverse flow, backward flow. So this is called as reverse and this is called as reversed and diastolic flow in umbilical artery. Then we have to take action. We have to take action. Reverse diastolic flow. So in case of IUGR, management is termination of pregnancy. If period of gestation is less than 34 weeks and changes are just raised in SD ratio, and admit the patient, give steroids, fetal monitoring, Doppler, okay. But if there is an absent and diastolic flow and there is a reverse and diastolic flow, then the treatment is termination of pregnancy. Termination of pregnancy. So this is the last topic, puerperal pyrexia, PYQ. Puerperal pyrexia means temperature. Temperature if more than 100.4 degree Celsius on 2 occasions 24 hours apart. Puerperal means after delivery, time period after delivery, approximately 42 days. 42 days. So this is called as puerperal pyrexia. Temperature more than 100.4 degrees Celsius on 2 occasions 24 hours apart after delivery. So most common site of infection in vaginal delivery is placental site. And in cesarean section, incision site. Vaginal delivery, placental site. Cesarean section, incision site. So cardiac output is maximum around 70% in intrapartum, postpartum और 32 weeks. कब होगा सबसे ज़्यादा cardiac output? Cardiac output immediate postpartum. Yes, postpartum. Because after delivery of placenta, there is a contraction of uterus. जितना भी blood है, वो सारा कहाँ जाएगा? Maternal circulation. After postpartum. So most maximum cardiac output immediate postpartum, then intrapartum at the time of labor, approximately 50% high, and then 32 weeks of gestation at around 40%. So 70% maximum cardiac output postpartum, 50% intrapartum, and around 40% 32 weeks of gestation. 32 weeks of gestation. Yes, Fahrenheit. Okay. So after delivery, cardiac output returns to normal by 10th day. By 10th day. Remains high up to 24 to 48 hours, but returns to normal by 10th day. By 10th day. So after delivery, rate of involution of uterus is around 1.25 centimeters per day. अब धीरे धीरे यूट्रस अपनी पोजीशन पे आएगा. 1.25 centimeters per day. Uterus become pelvic organ by 2 weeks. By 2 weeks, and return to normal non-pregnant state by 8 weeks if we are doing ultrasound, on ultrasound. After delivery, there is a shedding of endometrium. Shedding of endometrium. Or these secretions are called as lochia. Endometrial secretions are called as lochia. So this one is a physiological process. About 20 to 25 days shedding of endometrium after delivery. This is called as lochia. So sequence of lochia. Yes. So first 4 days. Secretions are red in color because of RBCs, red in color. Yes. So lochia rubra, red in color. Mostly RBCs are present. 4 to 10 days, lochia serosa, mucus is present. Lochia serosa, mucus is present. For 10 to 15 days, lochia alba, epithelial cells, presence of epithelial cells. 1 to 14 days, sequence of lochia. Lochia rubra, serosa and alba. If there is a foul smelling, it means infection. There is some infection. Most common infection postpartum, endometritis. So this is all about today's session. So I have tried to cover all the important topics of OBS. Then thank you to all of you. Thanks for your patience.